Good morning, everybody, and welcome to the meeting today of the Health and Wellbeing Board. The meeting today is open to the public, and thank you everybody for attending. My name is Councillor Argenzio, and I am the co-chair of the Health and Wellbeing Board. I'm going to pass on to Joanne, who is going to give us the housekeeping, and then I will ask two people quickly to introduce themselves around the room.
Please can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned for today. If there is an emergency evacuation, please take instruction from the council staff present. The assembly point is Tudor Square. The meeting today is open to the public and will be streamed live and for subsequent broadcast via the council's website. You should be aware that the council is a data controller under the Data Protection Act. Data collected during this webcast will be retained in accordance with the council's published policy. By entering the meeting room, you are consenting to be filmed and to the possible use of those images and sound recordings for webcasting. Any speakers, not members of the public who are speakers, but people speaking on an item, if I know that you're coming, you should have a name card. So if you could collect it and bring it up to the front when you speak, please. Thank you.
Okay, I've been told that people online can't hear me very well, so I'm going to ask people to introduce themselves. I'll start very quickly on the left, and if we can be quick with it.
Hello, Meredith, Teasdale, Strategic Director, Children, Sheffield City Council.
Thanks. Douglas Johnson, Chair of Housing.
Sarah Dew, Strategy and Partnerships Director, Sheffield Teaching Hospitals.
Judy Robinson, Chair of Sheffield Healthwatch.
Councillor Dorndale, Chair of Education, Children and Families Committee.
Lee Salisbury, GP in Sheffield and also Clinical Lead for Health Inequalities for Sheffield ICB.
Fiona Phoenix, Associate Dean, Sheffield Hallam University.
Alexis Chapel, Strategic Director for Adult Care and Wellbeing.
Yvonne Millard, Chief Nurse, Sheffield Children's.
Helen Sims, Chief Executive, Voluntary Action Sheffield.
Megan Ory, Chief Executive at SOAR Community, here as a voluntary sector representative.
James Drury, Director of Strategy, Sheffield Health and Social Care.
Rob Sykes, Chief Operating Officer, University of Sheffield.
Paul Ferguson, Superintendent, Neighbourhoods, Sheffield.
Zach McMurray, GP Medical Director for Sheffield within the ICB and Co-Chair of the Health and Wellbeing Board.
Greg Felt, Director of Public Health.
Officer?
Dan Spicer, Policy Officer for Sheffield City Council.
Joanne Cooper, Democratic Services.
And we have Alan supporting us on the tech. So thank you very much for that. I have apologies for absence, which is, I have apologies from Kate Martin and Emma Latimer. Are there any further apologies today? Okay, thank you. Declaration of interest. Does anybody wish to declare an interest? I'll put my hand up. I need to declare an interest in the long COVID item, as my partner has long COVID, and quite a few people are aware of that. So I'll try to not make it personal. So we have exclusion of press and public. There are no items on the agenda that require the exclusion of press and public, and I think we have the press in. And we have item 4, public questions, statements and petitions. And we have a few questions. And the way we're going to do this is I am going to ask for people who are asking questions either to come and sit and read the question, or when they've requested an officer to read the question, Joanne will read the question, and then we will answer them all together at the end. So could I, the first one is a question from Michael McEwen. I hope I've said that right, and Joanne is going to read this one.
Thank you. Michael's question is, what is the future of the long COVID rehabilitation hub in Sheffield.
Thank you. The second question is from Michael Nutt, who I believe is online. Michael, can you ask your question, please?
Unless they reply to us.
Michael?
Sorry, yes. I was just having a technical... You can hear me now?
Yes, please. Could you
Thank you.
your question? Thank you.
Yeah. Okay, great. Right, so my question is, well, I've got two. The first one is, Office of National Statistics indicates only a fraction of those suspected to have long COVID, even when affected significantly, are actually receiving care at specialist long COVID clinics. What work will be done by this board with this ICB, given financial allocations for long COVID were the same this year as last year, to investigate why there is such unmet demand for long COVID within the population, and how will this unmet demand be addressed within the ICB via education/awareness in the public and within primary care, so referrers. I did submit a report from long COVID support, which I co-authored, which evidences this idea that there is clear unmet demand across the nation. Yeah, so that's one question.
Do you want to ask the second as well, please?
Absolutely, yeah. So the second question was there a full public consultation for the review of the long COVID service within this ICB? And as might be expected, given a change of service was being considered, my understanding was that the four options were being considered. Two of them included decommissioning, one of them would be a change of service, and one of them would be keep it the same but in line with present demand. And if no, how did the ICB meet its legal requirement for patient involvement as per NHSE guidelines? I note that Healthwatch, the Healthwatch report, which will be discussed later, didn't query patients on the aspects of a change of service or closure of the long COVID service. I did put in a freedom of information request, and about, was there involvement, a full public involvement in the decision making around the future of the long COVID services, and within that, the answer seemed to reflect that the work that Healthwatch did was the patient involvement, but Healthwatch have confirmed that they weren't commissioned to do public involvement with respect to that question around the future of the service or a change of service. So yeah, complicated question, but hopefully that can be asked.
Thank you, Michael. And the next question, the two questions are from Fiona Hart. Fiona is actually online, but she would prefer the question to be asked by the officer.
Fiona Hart's question 1. Some patients report being discharged from the post-COVID services. Their condition is considered too complex because they have not recovered within the given time frame, or because they do not respond to the therapies provided. It seems logical that they are the ones that are most in need of expert treatment, but they are often left to cope alone. If the long COVID service is not currently equipped to deal with these patients, what is being done to raise and address this issue? Question 2. Repeat COVID infections often make long COVID sufferers' condition worse, and any COVID infection can lead to long COVID. The science on airborne transmissions and the efficacy of measures such as masking with FFP2 or FFP3 respirator masks, ventilation and air purification clearly shows that these measures are effective and necessary to reduce spread. What is being done to implement the recommendation from the Healthwatch report that recommends COVID safety measures that aim to reduce the risk of transmission and make people with long COVID safe enough to attend healthcare appointments? Thank you.
Thanks. The next two questions, they are being asked by people who are here in the room. Could Maria Ashmore and Carolyn Leary both come to the microphone, and then we'll listen to Maria's question first, and then Carolyn. Thank you.
Thank you. The board has pledged to embrace radical shifts. Could one such shift be ensuring that newly known ring-fence funding previously allocated for the long COVID hub is not simply lost? Often, vital resources disappear once ring-fencing is removed, despite ongoing need. At Sheffield ME and Fibromyalgia and Long COVID Group, we work closely with people living with long COVID, NHS long COVID hub staff, Healthwatch and others. There is a strong appetite to build on what we've learned from the pandemic and from treating ME to ensure Sheffield's next steps are considered, collaborative and inclusive. With the ME delivery plan due imminently from central government, Sheffield has the opportunity to be progressive, aligning with the work of the hubs and the voluntary sector to meet its requirements in ensuring those with long COVID are not forgotten. We propose exploring a model where patients receive wraparound support from both clinical and voluntary sector services, ensuring a more sustainable and patient-centred approach. Whilst we acknowledge that referrals to the hub have declined, this may reflect uncertainty around the service and other barriers for people and individuals in accessing the service rather than reduced need. Does the board agree that we should pause any decisions on the hub's future, and would members support genuine involvement of stakeholders in shaping its next steps?
Thank you. My name is Carolyn Leary. I'm currently chair of the Sheffield ME Fibromyalgia and Long COVID Group. We've seen a steady increase in inquiries from people living with long COVID in our wider area, South Yorkshire, North Derbyshire, which reflects the Office of National Statistics reporting of 2 million people self-reporting symptoms of long COVID, over 3% of the population. Some have understanding GPs, some have been referred to the long COVID hub where their situation is at least validated, and some have felt supported by engaging in programmes there of symptom management. But many are reporting, and it's echoed in the Healthwatch report, inadequate medical input to identify treatable symptoms. For example, POTS, which is postural orthostatic tachycardia syndrome, MCAS, which is mast cell activation syndrome, and other potentially treatable symptoms. Treating these can significantly improve people's quality of life and potential for them to either partially resume work or study or move on a little bit with their life. As the long COVID service faces a transition, can the Health and Wellbeing Board confirm that they've done and undertaken or seen a full needs analysis of the clinical needs of this patient group, including the epidemiology and the severity of long COVID in our area? And using this information, are there therefore plans to commission clinical services in line with the NHS commissioning process, which is a requirement of physician-led services? The other staff at Long COVID Hub are delightful, but we are missing the medical, clinical, physician-led input. Can this information be put out in the public domain? And strongly recommend the report that Michael Natt referred to at the very beginning, which is really, really excellent. Thank you.
Thanks. I'm going to pass on to Zach McMurray, who's going to answer the questions, and then I'll add Sarah whether she wants to add anything. Can I also mention that the health sub-scrutiny have a long COVID item on their agenda later in the year. So I know that Councillor Ruth Milson is very interested in this conversation today.
Thank you, Chair. I'm going to try and sort of keep the lines here in that I'm going to answer the question from a commissioning perspective, and then I'm really keen that we have a clinical conversation because I'm a practicing GP. I see patients with long COVID, chronic fatigue, chronic pain on a daily basis. So I think there are two parts to the conversation. So I think the commissioning bit, an honest reflection on the position that we're at with that. And then I think the bit around the clinical conversation, I'm really keen to get into that. And I think that's some of the things that are raised around the Healthwatch report. Some of it related purely to long COVID, some of it probably more generic type issues that we've talked about many times around resources and capacity and all the different parts of the system. So from a purely commissioning perspective, so this is my role as the medical director, as a commissioner in Sheffield, my understanding is that this was a service that effectively money came down from NHS England that was ring-fenced. So obviously COVID 5 years ago was a new presentation. It has been a pretty dramatic period. It's had massive consequences for the population. And funding was specifically ring-fenced from NHS England, came down with very tight criteria in how it could be used. And that was to invest in the service. And we did co-produce the service that is currently existing within Sheffield. That has now changed, and I think it's fair to say it's been difficult to get clarity as to whether the funding is still ring-fenced, whether the funding is sitting within a baseline, whether the funding is sitting across the South Yorkshire footprint or actually sits within Sheffield Place. And we now have that clarity. So I can only comment, having really had 2 or 3 weeks involved in this process, in that the funding we have now had confirmation is sitting within the Place budget. And as Place Commissioners, it is our job to work with partners to find out how we can actually use that resource, and it is most effectively for the entire population that we serve within Sheffield. And part of that is looking at the current model for the clinic, the satisfaction with the model, the things that are raised through the Healthwatch report, but also talking to a wide group of clinicians and talking to patients and trying to find out, is this the sort of model that we need for the future? Is it cost effective? Because it is an expensive model. And the argument is that you could get a lot more in a community setting if you used that money differently. Does it have to be specifically a clinic that is for patients with long COVID? And there are different views on that. I would say as a GP, I've got many patients with chronic fatigue and chronic pain who really could benefit for a slightly more generic type service. And I think that's part of the clinical conversation I'm keen to have. So the stage we're at, and I can't really comment on anything that's happened before, and I think there is a paper that's been floating around the system that I have no knowledge, no involvement with, which I think was a discussion paper that was produced within the central ICB. From a Place perspective, now that we are clear that we are responsible for commissioning the service, what we would like to do, and do it quite quickly over the next few months, is look at the service, take in all the feedback we've had about the service, and then have a clinically led conversation about how we take this forward. And some of that will be a realistic conversation about how much we can invest. The problem we've got is that we've got very limited resources within the NHS, as you're all aware. We're not going to get new money. We are working closely with hospital colleagues to try and release the DARSI opportunity, which is the efficiencies out of secondary care that can actually release more funding to do the left shift that people talk about. I mean, I can't admit to agreeing with everything that government's doing at the moment, but what I do agree with is effectively the specialist to the generalist and the hospital to the community. Because with limited resources, that is how we're going to look after the needs of the population. And that's a combination of medical input, and it's a combination of quite often the softer input. Voluntary sector colleagues work with us to deliver a lot of that. So we would really like to look at the totality of the funding that's available, what we're getting for that, what that's costing, and whether there are options for that to be used differently within either a more generic type service or used with different partners working with us within the community. So a lot of the supportive stuff, it might be that you want to invest more in that, because personally from a GP perspective, that's probably one of the biggest issues at the moment, but that's probably the clinical conversation. So apologies, it's a little bit of a non-answer. I'm just being honest. It's only really hit us. I think it's a great opportunity that we now know that this is commissioned from Place, and we know that it is funding that is no longer ring-fenced, so we can actually look at the whole, and we can try and hopefully together find a way of actually delivering this service for the future. So that's probably all I want to say around the commissioning part of it. I'm really keen that around the Healthwatch report, we don't miss the Healthwatch report, because I think there are a lot of little nuggets in there that are wider conversations that we're trying to have. But I think that would be the way that we would look at it from a commissioner within Sheffield Place.
Thanks, Zach. Sarah, would you like to add anything to that?
Thanks so much for your questions. So I think probably the area that I can most add isn't about the future of the service, because that is a commissioning question, but is more about the service that we've got at the moment and later on in the agenda when we talk about the Healthwatch report. That talks a bit about the journey we've gone on, I think, since then, because it's been quite an evolving service, as I think we've all referenced. So You asked a couple of questions around the model at the moment and how it works, and you're right to say there's a lot of therapy-led input in the model at the moment within the Long COVID Hub, but with consultant oversight where it's needed to provide that consultant input and medical leadership to direct people to the right services. You also asked a bit about what happens around discharge, and there's a set of support that we're commissioned to deliver, and when we've delivered all of that support and it doesn't feel like it's meeting people's needs or we've got nothing else to offer, then we either go back into primary care or into other services that we think might be most clinically relevant. You also asked a bit about how we're managing transmission and infection control. So now COVID has moved into our overall respiratory virus management from an infection control perspective, and the Long COVID Hub is under the same infection prevention control measures as the rest of our services. And I think it will be a similar story probably in other health and care services now, that we encourage people, if they're symptomatic with respiratory illness, to wear a mask if they're visiting, and for staff to have droplet PPE if they're symptomatic. And we always welcome people to wear face coverings if they'd like to, but it's now managed as part of business as usual from an infection control perspective alongside other respiratory viruses. So I hope that's helpful for just giving a bit of a response to some of your questions about where we are now, but I think the majority of your questions are about where we're going forward and into the future, and that's a question that sits with commissioning really, and I look forward to working with commissioners to answer some of those questions around what we've learned and where we go next.
Thank you. So that is it for today in terms of the questions that and the answers that we are able to provide today. What I'm going to suggest is that we send these questions with the relevant recordings, or wearing the recording of this meeting, to the member of the health scrutiny, so that they can pick it up before they have their item. I was subbing last week on it, and we discussed this very point. They were very interested in seeing where this was going, because obviously they have an agenda item later in the year, I think in the autumn. So it might be interesting to do a catch up with them. Councillor Milsom is the chair of that subcommittee. No, I'm sorry, yeah, sorry. But you can send us another question. Yeah, thank you. So thank you so much. We are moving on to item 6 on the, on to item 5, I should say. We have Fatima, who's going to present on Race Equality Partnership for Sheffield. We have allocated a maximum of 30 minutes to this item. Fatima is going to give us a report, and then we can ask questions if we need to.
Thank you. Can I check that you can hear me? I've never ever had a problem protecting my voice, but if it's for the benefit of the tape, I'm more than happy to do so. Good morning, everyone. My name's Fatima Khanchan. I'm proud to be the chair of the Sheffield Race Equality Partnership, and it's a shared role because I'm also a non-executive director of Sheffield Children's Hospital too, of which I'm very proud. So the whole purpose of the conversation today is very much a Yorkshire buy one, get one free situation. So we want to give you a bit of an overview of what we're doing in the Race Equality Partnership, but also have a conversation about potential areas of collaboration and also about some of the disparities that the data is showing. So Dan, who's going to be my glamorous assistant for this morning, are you okay to drive the slides? Or something? Oh, my apologies, an even more glamorous assistant. What's your name, my lovely? Adam, thank you so much. Alan, my apologies, Alan. Thank you for being supportive this morning. Really appreciate it. I've always wanted to do a Chris Whitty on a live stream, and you're giving me that bucket list moment. So, just for context, if we move to the first slide, please. For those of you that have not heard about the Race Equality Partnership before, it is a citywide initiative that was based on the Race Equality Commission, which took place during the time of COVID. And one of the things that I think it's really important to emphasise is the fact that many people testified during that process and shared some really traumatising lived experience about their utilisation of public services, their experiences of living in Sheffield, but more importantly, an aspiration for things to be different in light of the aftermath of the murder of George Floyd. and also the disproportionate impact of COVID on diverse communities. As an outcome of that process, one of the key elements that came from that was a real aspiration of Sheffield setting itself apart as a city of opportunity. So irrespective of your heritage or your path in life, you should be able to fulfil your potential and contribute actively to civic engagement, but also other services within the city, not to mention being able to contribute to both its economic prosperity and the decision-making of the city. I think one of the things that is really important to acknowledge is since that initiation and launch of that particular report, there has been a bit of a hiatus for a variety of reasons, but now that I'm in the post, I'm hoping to get the engineering going and go full throttle into some delivery. If we move on to the next slide, I think one of the things it's really important to emphasise is our aspiration of embedding race equity into the city goals. And the reason why that is important is because if you look at all 6 of those particular goals, one of them about being creative and entrepreneurial, a safe and caring Sheffield, the outcomes and feedback from that Race Equality Commission demonstrated that there were a number of people from ethnically diverse backgrounds that did not experience that. In addition to the outcomes that are already in the city goals, I think one of the most important things that we all need to acknowledge as a city is that diversity is our strength. At the end of the day, if you have got a diverse workforce, if you've got people that are coming from different perspectives, different thoughts, it enables your organisation to attract the best talent. It enables you to deliver the best high quality and safe services. But more importantly, you're the best in the field. So in addition to sort of the social and moral reasons of why this is important, I think one of the things we've got to recognise is as Sheffield wants to be the city where it's the best place in the country to live and work, it really needs to start seeing diversity and race equity as an opportunity to fulfil its potential, as well as a challenge that it needs to resolve. So if we move on, and thank you so much, you're doing a fantastic job. I want to talk to you a little bit about language. Now, the reason why this is important is because we are in a time, and I don't want to get into the political conversation, but I will acknowledge the elephant in the room, that there is an overt attack on equality, diversity and inclusion. It is perceived as woke, it's perceived as unnecessary, and it's perceived as a waste of time and money. I think I've just articulated the reasons why it's not a waste of money, but I also want to talk to you about some of the practicalities of why we've not managed to get to where we want to. The first thing is, and I really love this slide because I'm a visual learner, I don't know about you guys, but words do sort of hit me, but not in the same way as pictures. Most people working in the public sector and the private sector fully appreciate that the reality of people from ethnically diverse backgrounds, including me, do not experience life in the same way. So despite our best efforts to fulfill our potential, to go into sectors where we've never been before, forgive the Star Trek analogy, we sometimes don't always get to where we want to be because of imperceptible barriers. Now, whether they're intentional or unintentional, I'm not going to have the discussion about, but they exist. And we call them structurally embedded advantage. One of the ways in which we've tried to resolve it is through the lens of equality. Now, equality is basically treating everyone the same. The issue you've got with equality is if you treat everyone the same, you don't fully appreciate the path they've taken in life. You don't see their whole person, and you might hit a target, but you'll miss the point. So what we really want to move towards now is equity. So when we talk about equity, it's recognising that not everyone starts in the same place, and actually if we really want to support them getting to where we want them to go, whether in this context it's accessing health and care services, then we need to start to address things through the lens of equity, not equality. Are you still with me? Good. The next bit is, I'm a bit of a positive disruptor. Well, some people might not see it as positive, but I like to say that I am. And when we're working with elected members and people with influence, I want to move into the realms of social justice. Social justice is, if you stay with the analogy, if you're walking in a corridor and someone's put a box in front of you, what do most of you do? You walk around the box. You don't question why the box is there. You don't go, oh, someone move it out of the way. You just move around it. Whereas social justice questions why that box is there in the first place. Maybe it's a health and safety hazard, and you move it out of the way. Social justice is very much that. It's about recognising the elements of equity, but recognising those system-embedded advantages and removing them. And one of the joys of this particular agenda being linked to the political agenda and with people of influence, including all of you around this table, is we can very much move into the realms of social justice. But I'm also a lady that lives with FOMO. Do you know what FOMO is? For those that are not as au fait as I am with the young folk, it is fear of missing out. And inclusion is very much people missing out. So as well as addressing equity and social justice, I want people to be playing the game. Instead of watching, let's be a part of it. Now, this room is a really great example of how that can happen, because it's a place where solutions are discussed and decisions are made. Full inclusion would be those individuals being in this room, being a part of that conversation and enabling and co-creating the change. That's what true inclusion looks like. Another analogy could be you're invited to the party, but you're also able to dance to music that you actually like. Whichever one you prefer, you can use those analogies. If we move on to the next slide, thank you so much. The other bit is we can't talk about equity without going into the world of power and privilege. Now, some of you might get uncomfortable about that, but that's okay. And we need to lean into that discomfort. The reason why is because we need to understand the differences of the terminologies, but we've also got to realise that the legislative and statutory requirements do not go far enough. And what happens as a consequence is that we look at people through single lenses. So I sit here before you now as a rather gobby Asian woman, but I also have children. I also have a faith. I also live with a disability. I'm also an unpaid carer. All those different elements make me who I am. But the current silo way of working may not harness all of that. The other bit we've got to appreciate in the complex post-COVID world is recognising that there are other elements that impact people's outcomes of life, things like their ability to speak the language, things like their body image, and also their wealth. So I might be somebody that is in a position where I earn a decent wage and I might live in a nice area, but I still experience inequality because of the name that I have and the heritage that I present. And that is why we need to get much more sophisticated in our approach to race equity in that city. But equally, as a woman who wants to change the world, we've got to focus, because we can't sort it all out in one, can we? I mean, we're pretty awesome in Sheffield, but we've still got to do one step at a time. So one of the things that we've really got to think about is being intentional and consistent, which is why bringing you back on that focus of race equity is important. It doesn't mean that other protected characteristics don't benefit. If the tide goes up, all the boats rise. But the important element is that we're focused on one particular area because the data tells us that there is inequality. So if we move on, I just want to emphasise one final point before I talk you through the data. And that is because we know that good health is wealth, and wealth leads to good health. We know that people's experiences of living in a certain area, access to decent housing, good working conditions, good remuneration, job security, good food, all lead to better outcomes. If we're truly going to fulfil the aspiration of this commission, then we need to broaden the remit beyond health. But as anchor institutions and really influential players in the city, you can help us address all these elements. And it's in your interest to do so, because if we achieve this and we address some of the wider determinants of health, the outcome will be better health for all people in the city. And if we move on, some of the data will tell us that, but I want to talk to you a little bit about what we've been cracking on with since my arrival in, I think it was July. It's all a bit of a blur. The first thing is recognising the importance of leadership. And I'm hoping after this conversation today, if you're not sick of the sound of my voice, you will be joining the leadership of reps, because that's really important that everyone is leading from every single seat. The other part is the importance of good governance. So one of the conversations I'd really like to have with you today is how we use the governance of the Health and Wellbeing Board to deliver some of the aspirations that reps needs to deliver. We also need to get into the realms of accountability. Now, I don't mean a carrot or a stick situation, but what I do mean is the fact that you are equally in a position to hold each other accountable for the delivery of this, but through the lens of kindness. So if someone is not moving in the direction we want them to go, it's about showing them what good practice looks like. It's about supporting them with some of the challenges. Because if this was easy, we'd have cracked it. It's hard. The other part is really recognising that we need to amplify the lived experience of people who shared their trauma with us, but are also banging on the door to be a part of the solution. Now, in order for us to do that, we go back to the power and privilege dynamic, because we have to give something up to give back to the people. And are we courageous enough to do that is something we might want to think about today. The other element is working within the NHS, which I do and I'm proud to do so. We know that if our service does not reflect its communities, it does not give an equitable, safe or high quality service. Not because our workforce is not incredible, but because people don't trust it. And sometimes if you're designing and delivering services that don't represent the people, or the people aren't part of that creation process, you don't know what you don't know. And what happens is you perpetuate that inequality. So representation is absolutely important at every single level of this room. So this room, all the levels beneath it, to the grassroots of the community. And the reason why that is important is because, like I say, high quality, safe services are important, but also because we know that those communities are receiving some of the worst outcomes. So things need to change. And then the final bit is the mantra of Elvis, really, which is a little less conversation, a little more action, please. So the importance of being able to demonstrate the change. Because if there's anything people need right now, it's hope. Hope that things are changing, hope that things will get better. Being able to tell the story of the impact and the change we're making in Sheffield is crucial to our success, just as much as doing the work. So moving on to the art of the possible, if we keep going, thank you. I'm not going to overlabour these slides because we can circulate them to you and you can look at them at your leisure. But I think the data speaks for itself. We know that people from ethnically diverse backgrounds are more likely to live in deprived areas. I know I did because I grew up in Pitsmoor and Fir Vale. It's a very deprived area. Darnall was where I was born, very proud of it. And we do know that the data shows that people do die earlier depending on their postcode. I don't think that's fair as a mum of 2 kids. Don't know what other people feel. If we move on, there's also some reports that came out really recently, and for those of you that haven't heard of the Race Health Observatory, I encourage you to Google it. They are fabulous when it comes to data-led decision making. One of the things that I mentioned about the importance of a diverse workforce, ensuring that our services are inclusive, is to address the manifestation of a lack of trust. Now, if you are working in the public sector, you know that people from ethnically diverse backgrounds tend to be reluctant when it comes to engaging with us, when it comes to engagement, when it comes to service delivery. One of the main reasons for that is a lack of trust. And part of that is due to their experience of discrimination. Really important that we consider that. If we move on, there's also something about the cold, hard cash. So it isn't just a social and moral reason for us to address racism, it's because it costs us money. So people who are from ethnically diverse backgrounds, who live in deprived communities, will present later in services, which will result in a higher cost of services. So it's in our economic interest, in a time where we are very fiscally tight in both the health and care sector, to proactively try and address racism within the services we deliver, but also when it comes to retaining our workforce, because it's far cheaper to keep the workforce that we've got that are really skilled and specialised than to re-recruit because of their experiences within our organisation. And if we keep going, the other part, and again, lived experience is very much the central of what we do. The data we receive from people working in the grassroots of our communities was a real feeling that they are underrepresented in senior roles. I'm not going to highlight the obvious, but if you look around this room, I think that would be a fair reflection. There's also some recognition of a disproportionate disciplinary action and bullying reports. If you look at the Workforce Race Equality Standard, which many NHS organisations need to submit, you can see that that is true. They've also reported experiences of exclusion in services and the need for building trust, which we've already articulated. The other thing I would say is we don't need to go too far back to reflect on the manifestation of racism within our communities. If we reflect on what happened last summer and the experiences of our workforce and people living within our communities, it is not just within our financial, social and moral interest to do this, but to keep a stable community, we need to be ensuring that there is less division and more cohesion. And as a microcosm of society, both the health and care system have got a real role to play in that space. So if we keep going, and this is the bit where really Greg should be talking about it, because you're the expert, aren't you, rather than me. But again, the disproportionality of ethnically diverse backgrounds developing diabetes, stroke and heart disease is very significant. We've talked about life expectancy. But what we haven't really acknowledged is when we're talking about ethnically diverse backgrounds, I don't just mean people with a darker skin colour, I mean the Roma and the Gypsy community, who also really experience barriers to access. But also, as I mentioned at the beginning, health is wealth. So where you live, your access to services, green spaces, transport, all link to your health outcomes. So how do we move on from here? Because I think I've scared you all enough, haven't I? But hope is coming, it really is. And the first thing is, if we move on to the building blocks of change, one of the key things is you're already on it. you're already talking about all the things that we need to address, which is a healthy standard of living, healthy communities and good work for all, with racism and discrimination going all the way through it. So I think there's a really great opportunity for us to collaborate and do some amazing work in this space. And if we move on to the next slide, again, just reiterating the fact that race equity could really be a fantastic enabler in this space. If we keep moving on, because I think they're sick of the sound of my voice now, Ellen, aren't they? So we'll bring it to a close. This slide really talks about how this can really add value, which I think I've already emphasised enough. And I want to labour the last slide, if you move on to the next one, please, which is an ask. Because Fatima never really turns up to a meeting without asking for something, I'm afraid. And the first one is, there's a real opportunity for us to align our strategic outcomes with the work that we're doing on racial disparities, with the work that you all do within your organisations. I know from some of the visits that I've done, so Paul, I've had the privilege of visiting South Yorkshire Police, thank you for your kind hospitality, and also Fiona went to visit Liz and Sam at Sheffield University, thank you for that. So there's some really good work taking place already, but what we want to do is build on that and explore how can we embed race equity as part of your accountability structures, really making that change happen. How can we get the people with lived experience to support you to co-create the change? Is a really important question I wanted to ask. But also, how can I help you as the chair with the amazing partnership to get to where we need to go, which is a much more inclusive and proper city? So if we move on to the final slide, and that is all I wanted to say, Councillor. It would be great to have a conversation about how we can move this on, but also if colleagues have got any questions, I'm more than happy to take them. Apologies for covering so much in a short space of time.
Thank you so much, Fatima. First of all, Joanne, could we circulate the slides? Because I don't think they were distributed. Could they be either published on the website with the agenda or with the minutes when the minutes come?
Yeah, I can publish them with the agenda in the next couple of days.
Thank you.
Thank you. Are there any questions or comments from Greg?
Fatima, thanks. I never get bored of your voice, so don't worry about that bit. Nobody likes the music I like to dance to. No. But
let's take it outside, people. Let's take it outside.
Yeah, more seriously. Just one quick thought. I'd always sort of have slight antibodies on it's a public health priority, because then it gets pigeonholed inappropriately. So I do worry a little bit about that.
No, so just to be clear, it's everyone's priority.
Yeah, that's where I get to. But everyone says, oh, it's a public health, Greg will sort it, and he won't. He'll try, but he won't sort it by himself. 3 thoughts. Remind the board that building block number 1 of our strategy that you have all signed off is tackling racism, systemic discrimination, etc., etc., etc. We said 3 things: diversity on boards. We don't do very well, not as many other places. Measuring it and being anti-racist. I was dead struck by what you brought to the room. The elephant in the room is the attack on woke, DEI, etc. But I would reject the attack, and I think the board should reject the attack. That's a fundamental part of being anti-racist. So I think we should kind of be really, really clear on that. I was dead struck by what you said about co-produced lived experience. We do okay on that for some things, maybe not everything within the city of Sheffield, but we have good track record in some programmes actually, and I think I'm really struck by it's a really, really, really powerful tool. It gives no people nowhere to hide. Maybe we can do more on institutionalising the co-production of our approach to anti-racism, etc. And the last point, the measuring it bit. I'm always, as you say, more interested in it. And what do we do about this? I don't know what all of the institutions are doing around kind of being anti-racist, etc. I've heard firsthand some of the ICB stuff. Christine Joy, I'll name check her, has done a great job actually. I don't know whether that applies to all of our organisations. The question for me, for myself and the board, is what does this board add over and above the individual actors in the machine? I don't know the answer to that. It's not an easy one to answer. But we should always come back to applying the lens that you've asked us to apply to all of our conversations. I'll stop.
Chair, am I okay to respond, or do you want me to? Okay, so the first thing is diversity on boards. It is possible. We've delivered it. But I think there is something about doing it in the right way and avoiding tokenism, which I think we're very much committed to. Your point about, you know, boards having a role on rejecting the sort of attack on diversity, equality and inclusion, I've not heard that. I've not heard any board in Sheffield stand up and say diversity is an asset. It'd be great to hear it. I think it would really assure people from diverse backgrounds and people that are working within our organisations on this agenda that it is important and it is a priority. And I think sometimes we assume people know stuff, but hearing it again is no bad thing. The elements of anti-racism, so I have been working with Christine Joy in my other day job about an approach to anti-racism across the regions, actually West Yorkshire and South Yorkshire being one. Happy to take that as an action and bring something back. The other bit about measuring the impact, well, I would sort of say that we do measure the impact actually. There's the Workforce Race Equality Standard, local government do its own reporting. What would be really great is for us all to commit to measuring the same thing. I think if we agreed that today, that would be really radical. Because we need to understand where we're starting to be able to demonstrate whether we're going anywhere. But the challenge we've got with the different sectors is local government measure one thing, the NHS measure another. I'm sure that the higher education system also measure other things. If we all commit to measuring one or two specific areas, I think that would be a proper game changer. But co-production, again, is very much something that we all aspire to do. My question would be, who are you doing it with?
Thank you. I have a number of people who have indicated that they want to come in. So I've got Lee and Meredith, and then I'll take Alexis and James. So could you maybe do both your comments, questions, and I'll let Fatima respond.
I'm trying to think of how to put this in a question. Thank you. Really welcome what you say. I'm sure you know I think this is hitting the ground at a really good time because we've been discussing this for 15, 20 years. And certainly when I got into this space, so I work in inequalities within health, within Sheffield, the response was always, well, it's nothing to do with health. Do you know, it's all the wider determinants. And actually now we know, do you know, that's just a cop-out. We're all involved. And your mantra of being healthy keeps you wealthier, being poor makes you sick, do you know, and having worked in First Part for 30 years, I see that, I know that. I think we also understand that areas where there's the least inequality, whether we're talking about poverty, which we're going to talk about later, or whether we're talking about race, and often, as you know, there's an overlap, where there's the least inequality, everybody does better. So if you improve the life expectancy of the poorest and the most excluded, everybody's life expectancy goes up, and studies have proved that over the years. So it's not an argument that we should be having to make again, but we do. And I think part of the problem that we face is that the systems that we work in, the big systems, have inequality embedded within them. They do at every level. They do globally. They do locally as well. And I think your presentation is really helpful in provoking us all to think, in spite of the system, what is my role in this and what can I do? So I would, from the NHS point of view, from the ICB point of view, point you to what we're doing in the North East Sheffield. I don't know if you've come across that. So that is actively taking NHS money to invest in communities and work with them, not do to them. And that is absolutely the key in all of this. To improve people's well-being and happiness on the understanding that that's likely to improve their health, and that's going to be money well spent. And it's not just about health, it's about all the things you talked about, you know, involvement in the civic life, improving people's job expectancies and wages, that improves the tax, everything benefits. It's a bit of a no-brainer. But we just have to be aware that actually we're working in a system where not everybody gets that, and to be laser focused on spotting where inequality is happening. And, you know, we could talk about some of the issues that's come up from the long COVID clinic as well. That is not representative of the people who have suffered with COVID, and we know that. And that's not to say that everybody there doesn't have a need, but is it meeting the wider population need? So I suppose my question back to you is, you know, how can we work together to really improve people's awareness even more and actually amplify the voice? I would say, on behalf of the trusts who are here, that people are on board with this, and I know that each of the trusts are actively looking at this and working together, which I think is really helpful as well. So was there a question in there, Angela? I'm sorry if there wasn't.
No, comments are fine. I'll take Meredith and then go back to Fiona.
Thank you, Fatima. Thank you, Fatima. I think it's really powerful what you presented, and I think that it's really positive having you as a positive disruptor leading the work around the race equality partnership. I think for me, I think the link with the gender item around healthy child development is really key. We talk within there about the SEND manifesto, Special Educational Needs Disability Manifesto. We know the impact of children not gaining a good level of development at that earliest stage. We also know that that overlays with our areas of most disadvantage, and also there is an overlay around our families from minority ethnic backgrounds, from a range of different backgrounds. We know that our children who are in Sheffield Inclusion Centre and who are more likely to be excluded are children who are Roma, who are white, black, Caribbean background. So there is something, and I know that you've been working with us in Learn Sheffield and schools about how we address those issues, because actually if we get that right at the earliest stage, both how we are as community and ensure that we are anti-racist, but also how we are improving life chances of our children, then we gain that better quality and quantity of life in the long term. So I don't think it's a question, I think it's more just how do you keep on being that positive disruptor to challenge us to make the right decisions and to work with our colleagues to co-produce the right answers.
There's a positive disruptor in the room.
I mean, what can I say wherever I go? May I respond, Chair, to those two reflections, please? So the first thing, Dr. Salisbury, thank you so much for that incredible feedback. I think one of the questions I heard from you was, what can you do? And I think one of the most important challenges that we have on the race equity agenda is the question of whataboutery. So every time I sit in a room, I talk about race, someone talks to me about another protected characteristic, as if they're separate to each other. And actually we need to start talking about intersectionality, and Meredith mentioned this just now, which is people are not just defined by their race, but they are impacted negatively as a consequence of their race. And I think the work that you've done and the work that Emma Latimer does, of whom I'm a massive fan, really demonstrates the fact that actually if you give power back to the people with resources, you hold the accountability, but you give them the autonomy, they can really make change happen. The problem you've got is that not everyone believes it. So my answer to you is, and when you ask me what you can do, is be an ally. Appreciative inquiry is incredible when it comes to asking people, so why do you think that? Well, actually the data says this. And actually there's a real great example of good practice here that enables the change. But also I think in the answer to your question about what can we do together, I love playing with others. So, you know, if you want me to do a visit, if you want to have a further conversation about some of the impacts and good practice, we can showcase that and encourage other PCNs, other parts of the region to adopt it and support it too. In answer to your question, Meredith, firstly, I love playing with you. I think we're going to have a lot of fun together. One of the really interesting elements of feedback I've seen recently is a report about children in care and their experiences of those children from diverse backgrounds, and the fact that sometimes their heritage and their individual identity isn't always nurtured in those spaces. I think that's the first thing I'd say we could really do some work on together. The second thing, and I think it's really important, is discrimination is not something you're born with, it's learned. And our education system has structurally embedded advantage. So I would encourage you, when you all go home tonight, to Google a video which has some dolls in it. I don't know if you've seen it, where they have a white doll and a black doll, and they ask children about 7 years old, who is the good doll? Who's the bad doll? Who's the ugly doll? Who's the beautiful doll? And you'd be shocked at the answers. So there's something about how we work with you, Meredith, and the educators of the city, and I'm really excited to be visiting you in the next couple of months, where we have a conversation about how we develop our future generations to be really inclusive, but also to help them navigate a 21st century world where the barriers and the challenges are not just in the, Android world, but they're in the virtual as well.
Thank you. Fatima needs to leave it in 5 minutes. So I'm going to take the other 3 people that want to contribute and then give Fatima the last word. So I have Alexis, then James, and then Paul.
First of all, I just want to say really helpful and powerful presentation. I thought it was really good, and particularly I like to focus on equity, justice and inclusion, because I think absolutely that's where we need to focus where energies, and I agree with you about how do we focus and go forward. Couple of things, thinking about discussion, what can we do, is I agree with you about measuring in the same way, and from the care sector there is 17,500 care workforce across the city and about 329 providers, and one of the commitments that we made through the Adults Policy Committee was to work to the workforce race equality standard for all care providers in the city, which is a significant proportion, and we are nearly there in meeting that standard. So it means that basically both NHS and care systems in the city will be working to the same standard, which to me is quite a powerful statement for the city, and becoming anti-racist, but also becoming us a workforce that absolutely represents our communities and taking it forward. So for me, that's my commitment to you, that we have a team who are working actively towards achieving that with Skills for Care and with colleagues. And what I could do is put them in touch with you to not only show the demonstration of the progress made, but also we've taken that approach through engaging and co-producing with the care sector workforce, and to really work that in that really meaningful way. Because many things that you've said is what I've heard when I've met with many people across the city over the years. And actually for me it's been important about what can we do practically that shows you're making a difference, and being meaningful about that, and not just saying you're going to do something but actually doing it in a practical way. So for me that's something that I could connect our teams to you to go and do, and I think that could be hopefully showed as quite a positive, because I think we'll be one of the first to become in the care sector to do that across the piece. Equally, we have committed to improving the outcomes for overseas workers and for those who are affected by modern slavery, because that's also a significant issue that we've got to consider and actually talk openly about, and particularly you'll hear later today about the care and wellbeing contract. That's something that we've worked with Home Office and also providers, and also with trade unions about, and I think for me it's been quite a powerful exercise, because it's really showed us actually the outcomes for people could be significantly poor if we don't actually talk about some of these gritty issues as well. So I could share that work with you, and be really good to highlight that as perhaps as a commitment into the ambitions that you have. The final bit I was going to say is, what I quite like as a term now is invest to grow, because it's a conversation we start to have within ADAS and within some of the social care futures and think local act personal, but instead of thinking invest to save, thinking about invest to grow, because every pound that we invest and we think in a different way is actually supporting people's potentials to thrive and flourish and go forward. And for me that's a mindset that I've started to come into and to go forward. And so to me, when I was thinking about your presentation and thinking about what can we do, perhaps that's a mindset we start to take within the Health and Wellbeing Board and across partners, is this is about invest to grow and to enable people to thrive and flourish no matter who they are, where they are, and what part of the city they live in.
James.
So before I come to what I was going to say, Alexis, that's amazing that we can align the measures like that. Thank you, that's a really good step forward. We're clearly all on the same page here, and it flows through all of our strategies and all the things that we're trying to do, so that's a good start. But you talk about trust as well, and people don't necessarily know what it is we're trying to do, or why we're trying to do it, or what our commitment is. Anything the partnership can do to help us amplify that and build trust with communities about what we are doing, why we're doing it, and how we need to work together, because we can't do it on our own, and we might well be doing the wrong things if we try. So that might be one of the bits where the partnership can help us amplify that and be more accountable to our communities.
And finally, Paul.
Thank you. The question you asked around commitment to be an anti-racist organisation, I wanted to sort of say in this forum publicly that South Yorkshire Police are absolutely committed to that. And we mentioned the rhetoric coming in, particularly from America and other places, around this sort of anti-woke agenda. I wanted to say that our Chief Constable is absolutely committed to not falling into that trap. Our Deputy Chief Constable is our lead on the Police Race Action Plan. I'm her deputy, and it's some work that we're proud to do to change policing. And when I say policing, I mean internally, so we know that we are not reflective of society. So your comments there in your presentation around missing out on opportunity to attract the best people into the organisation, we are not there. We are more white than the communities we serve, which undermines our ability to reflect the communities we serve, which undermines confidence in policing. So we have more work to do in terms of recruitment, retention and progression. From our external basis, there are some significant differentials in society, and within the context of this Health and Wellbeing Board, they are across almost every measure, but in particular, young black people are 60% more likely to be victim of knife crime than a white young person. A young black person is 4 times more likely to be victim of gun crime than a white person. You know, these are the real sharp ends of health and well-being, because these are life-threatening scenarios. And if you're black in particular, you're more likely to be stabbed or more likely to be shot than a white person. And I think they're huge challenges for us. It's one thing for me to say those stark things, another to think the obvious retort is also what you're doing about it. I think you have this, but I would, like the opportunity to share, if that's possible, in terms of our plan to address all those issues. We are not naive enough to think we can wave a magic wand and think there will be quick fixes. These are some real long-term entrenched issues. So, for instance, we take into our custody a disproportionate number of people who are black, who are suffering from mental health crisis. So that sounds like an abusive use of police powers. We disproportionately take black people off the streets and when they're in crisis. We do that because they're in crisis on the street, and we take them to a hospital to be assessed for mental health or treatment. There's a whole range of societal issues in there, of which the policing part is right at the tail end. Which goes, I think, to Lee's point, so these are absolutely systemic issues that are going to take a long time to address and resolve. But we have a plan. It is transparent, it brings accountability, and it's causing policing to change and to alter to get us to a better place. So I hope, in terms of the discussion point there, I'm hoping I'm giving you some reassurance about the policing part of our response to this fundamental challenge. Thank you.
Fatima, before you come in, I just want to make one comment myself, just because I raised this yesterday when we were looking at this element in the committee I was chairing. I think it's also important to acknowledge the fact that you've already mentioned that here we are sitting here, and just looking around, we can see that we're not very diverse. And I think it will take time, but we also have to make a commitment as an organisation to remove the barriers that prevent people from a diverse background to go to the top and senior positions in organisations, so that we don't have that tokenistic kind of approach to say, oh, we're very white, let's get someone who's not white on the board so we look better. But we actually have the best people in leadership, so that one day around here we will be more representative of the very diverse city that we are.
Thank you so much. I'm going to attempt to summarise a response on all those questions. If I can, I'll respond to you first of all, Chair. So often I get called in my day job to support organisations improve their diversity of representation through the recruitment and retention processes. If I had £1 for every time they told me, oh, Fatima, we've tried really hard, but they're not out there, I wouldn't be here. I'd be on a beach somewhere living it up. They are there. I'm here. I'm here because someone gave me an opportunity, they saw my potential, and they helped me navigate a system that sadly is set up against me. And there are solutions. We have an inclusive recruitment toolkit that we created in West Yorkshire. It's available online. You can have it. You can start using it tomorrow. And I can make a commitment as an action chair to share that with everybody. But what I would also advocate, and you're absolutely right, is to avoid tokenism. Because it's not enough to be in the room if your hands are tied behind your back. We need to support people to develop the capability to be in that room and to contribute impactfully, and to help support the outcomes and strategic aspirations for that organisation. They do exist, we just need to help you find them and help you get them into those rooms of power. But again, there are a number of examples where people have taken positive action, and it's not only changed the dynamic of the conversation, it's enabled them to deliver far more inclusive outcomes. So again, completely support your call to action. Paul, really great feedback about the work of South Yorkshire Police. It was really wonderful to visit them. Laurie and Alia in particular doing a fantastic job. One of the things I would say, though, is the importance of the trust element, which you've alluded to regarding the challenges in certain crime areas. We do have a number of community influencers who are part of the infrastructure, of the Race Equality Commission. And one of the things I think we could really add value is how we collaborate with you in that space to harness those trusted influencers to help you with some of the work that you're doing. Because as you say, if they're not trusted by the communities, no matter how wonderful the work is, it won't reach the people that need it the most. But again, we can take that outside. In the sort of context of evaluation, Rob, I know you didn't get a chance to say anything about the amazing work that the University of Sheffield are doing in regards to evaluation and the race equity work that you're doing, but I think that could really support what we're doing as a race equality partnership. So I'm going to be cheeky and ask you for a coffee, if that's all right, to have a convo about that. I'm a lady who's not shy in making the first move, as they say. The bit that you said, James, about trusted influencers and involvement, as somebody who's got a massive background in engagement and involvement, it's not easy. And sometimes the people that are giving you contributions and shaping your decisions are carrying a lot of trauma and lived experience. So actually it's really important that we support them by developing their capability and creating safe spaces for them to contribute. And again, James, we can have that conversation outside. And I think the other thing that is really, really important, and it goes to your point, Alexis, which I was really, really pleased to hear, which was, you know, we don't measure the same thing, but wouldn't it be amazing as a health and wellbeing board if we all committed to using the RES and all of us using the same standards and measuring the same standards? There's about 4 or 5 organisations that already do it. We've got 6. I'm sure that would be a great win, just putting it on the table. The second bit, and I love the way you said it, Alexis, if I can call you Alexis, is this positive mindset. Like sometimes people address race equity like it's a deficit thing. It's not. It's an amazing opportunity to make your organisations even better than they already are. So one of the things this board can do as allies and hopefully now advocates for this agenda is to articulate the positive narrative of actually it adds value. It's not something that you have to do because it's mandatory or, you know, the legislation tells us to do it and we've got to tick the box. Actually, no, it's a great opportunity for us as organisations to be the best that we can be. And I think some of the work that you've done regarding the numbers and change is great. But the one thought I will leave you with is that every number is a person. Every person has a story. And what I always try to do in the work that I do is show you the numbers, but tell you the stories. Let's start telling some stories about what Sheffield is and what Sheffield can be. And if I may, Chair, it'd be really great to maybe come back in 6 months if we commit to starting with the RES data, to maybe doing some benchmarking, but also explore where we can go from here. Thank you.
I would be very happy with that if people agree. So we thank you so much, Fatima, for coming and for very lively presentation discussion. So we are asked to note the report. We will circulate the slides and invite Fatima back in 6 months. Dan, could you add that to the work programme, please? Thank you. And we have now item 6, which is the Healthwatch update. And I think Judy is going to lead with that.
The update this time is a bit different to the one I normally do. It's in the form of an audio originally made for the long COVID memorial event, appropriate to look at long COVID at this anniversary time. And it's a story of a real person called Fran and her own experience of long COVID. And by way of a little bit of introduction, I think a thank you to Fran for, we were just hearing people talking about the pain of that experience, and she talks about that very eloquently. So thank you to her. It illustrates, I think, what Healthwatch tries to do, which is to put people's experience at the centre of decision-making about health and social care. And putting that at the heart is a really important principle. Fran acknowledges that she has a lot of support, and that's not true for many people with long COVID. And the presentation that colleagues from Healthwatch are doing shortly will explain something about that support, where it works, where it doesn't work. So I think we're going to hear the audio, and then they will carry on under item 7. Thank you.
My name is Fran Haddock.
And firstly, I want to express my heartfelt compassion to everyone mourning loved ones lost to COVID today. I'm here to try my best to speak for everyone whose health has been permanently damaged by COVID, and many who, like me, are too sick to leave their house to attend events like this. I'm recording this speech from my bed, the place I've been confined to for 2 years. A single COVID infection decimated my life in 2022. Although I wasn't in full health before this due to mild ME/CFS, I was able to work as a veterinary surgeon, socialise, go on holidays and spend time outdoors, the place I love the most. One COVID infection rapidly left me confined to a dark room, unable to sit up, walk to the toilet or even open my eyes for more than a few seconds due to relentless and torturous symptoms. From fatigue and weakness so severe I often couldn't even move my legs in bed or turn over, to vertigo and head pressure so extreme I couldn't even read a single sentence. I was in this state for over a year. Due to that infection, I now have diagnoses of long COVID, severe ME, often known as ME/CFS, or less preferably chronic fatigue syndrome, POTS and dysautonomia, vestibular migraine and more, and I'm completely reliant on others for daily care such as washing, food and medical admin. There is so much misunderstanding around long COVID, such as incorrect blanket blaming on vaccinations, believing that everyone recovers, believing it only affects adults, or people thinking it is quote-unquote just a bit of tiredness. I'm someone who exists in the community of people most severely affected, and it is heartbreaking every day. Some of my friends are so sick they cannot tolerate any light, sound or stimulation. Some are so sick they cannot physically swallow or chew and need tube feeding. I have friends who have died, sometimes from the disease itself, or due to such poor quality of life and lack of treatments. I know many who have taken their own life or died by euthanasia or assisted suicide. Despite this reality, instead of empathy from the general public, a common reaction is being actively mocked. Treatment options through the NHS are pitiful, and many cases are still psychologised by doctors. Despite being in this severe category, there are reasons why I see myself as one of the lucky ones. I have an amazing family and partner, the privilege of adequate care that means I don't have to overexert, a safe home and financial security, an understanding GP and access to private treatments, which have helped me hugely. Because of all of this, I've been able to improve to the point of being able to sit up, talk and use screens a little. Quality of life is so poor in the severe spectrums of this disease that we are really asking for so little to give us reason to keep going. A little less suffering, being able to open the curtains and see the sky. For me, being able to leave my house and touch some grass would be just incredible. Although long COVID can and does affect anyone, the chances of acquiring it and the consequences you do are not shared equally. Similarly to the disease ME, long COVID disproportionately affects women. One of the main reasons ME was previously treated as hysteria. But there is also data to show that racially marginalised groups, trans folk and other marginalised groups are more likely to be affected by long COVID. And once you have long COVID, the ability to survive and improve hugely comes down to privilege, and it shouldn't be that way. Factors such as, do you have enough money to stay off work and to be able to afford private treatments? Do you have a family who will care for you? Is your pain more likely to be dismissed by doctors? Through the incredible online community, I've met people who have suffered shameful neglect, gaslighting and mistreatment with this disease by anyone from their closest family to medical professions to politicians and society itself. We deserve so much better and we are asking for so little. People say long COVID is a new disease, and while some aspects may be specific to SARS-CoV-2, the stigmatisation and neglect of post-infection diseases is not new. 5 years is a long time to have a disease which is systemically ignored and psychologised, but we cannot forget the people who have had ME, most frequently induced by infections, for decades on end, many who are completely bedbound or housebound. People with ME were the first to raise the alarm about COVID being a mass disabling event before long COVID even had a name. And unfortunately, they were right. Cases of ME are roughly 15 times higher than pre-pandemic. Roughly 1 in 10 COVID infections leads to long COVID, and the chances increases with every repeated infection, and roughly up to 50% of people with long COVID meet the criteria for ME. It is because of the neglect of ME and its comorbidities that we have no cure and poor recognition of long COVID and why the world was not in a position to deal with it. Psychologists spent years relentlessly pushing the idea that ME was a psychosomatic or psychosocial disease and recommending behavioural therapy, which at the least did nothing and at the worst made people significantly worse. ME and long COVID are biological diseases, and we are now reaping the consequences more than ever of the years of misinformation. This means that people with long COVID are known to be prescribed disproven incarcerated. Today, everyone complications from this virus. I'm also always aware that COVID is not over. It is still killing people and destroying lives by giving them a whole spectrum of long-term health conditions. Long COVID clinics in the UK are closing down. In the US, Trump is terminating long COVID advisory committees. Some of the public, understandably, are so desperate to forget the traumatic early years that they are willing to completely disappear those of us who are still living in isolation due to the ongoing pandemic, from either being too sick to leave the house or simply not being able to risk catching another COVID infection. As well as thinking about everyone who's had long COVID for 5 years, I'm thinking about everyone who's been shielding for 5 years and feels completely abandoned. Those of us still having to shield aren't asking for lockdowns again. We're asking for some basic precautions that can make public spaces safer, masks in medical settings, options for masked events with clean air and testing, air purifiers and better ventilation in schools and nurseries to protect kids. I'm sure you're not necessarily the audience who needs to hear this, but I would love non-disabled people to reflect on the fragility of their own health today. Not so many years ago, I was at the peak of health, training for a marathon. I'd never imagined, only aged 34, I'd be too sick to even leave my house and too sick to work. It's about time we recognise that repeated COVID infections are not good for our health and it isn't something we should just accept. Let's take a moment to look around and remember the people who can't be here today and who have been made invisible, some of whom have contributed messages that are hanging on the tree today. Let's read them and think about how we can bring back some of the spirit of community care and inclusivity that society embraced at the start of the pandemic. And to my fellow disabled, chronically ill and COVID cautious community, I want to say that our lives are beautiful and we are deserving of care, belief, treatment options and a world that we can access. And absolutely no government rhetoric or public narrative can change that. Thank you so much for listening.
Thank you. We're going on to straight into item 7, which is the long COVID report. There is a maximum time allocated to this item of 30 minutes. Could you please introduce yourselves and then just take it away from us? Thank you.
Hello, I'm Lucy Davis. I'm the Chief Officer of Healthwatch Sheffield. Hi, Maria Ashmore. Should have introduced myself earlier. I'm the very new Director of the Sheffield ME and Fibromyalgia and Long COVID group.
I'm Natasha Munoz. I was the lead on the Long COVID project with Healthwatch and Voluntary Action Sheffield, and I'm currently Head of Partnerships at Voluntary Action Sheffield.
So I'm going to start before passing to my colleagues. The project we've come to speak about today was commissioned originally by Sheffield Teaching Hospitals and at the time Sheffield CCG. And we'd like to start by recognising the commitment and investment that both those organisations made to working with us in this way through the project over years of this work. It was more than an exercise to gather people's views. It was a co-design project which really was centred on the needs of communities who weren't coming forward to access long COVID support. And whilst it started prompted in part by the question about why some people weren't coming forward for that support, actually the journeys that we heard and the work that we did cut right across the system and right across services and parts of people's lives. And it really didn't focus on just that question about the specialist service itself, which is why it's really fitting that it comes here, because this board is the right place to consider that broad question about people's lives and the way
different bits of the system come together to impact them. So we really hope that today's discussion can take the learning from the work and identify actions that we can take in Sheffield to do better for people like Fran and many others whose lives have been turned upside down by long COVID. In a moment, I'm going to pass to Natasha, who led this project. She'll bring to life the journey that we went on and what we heard. And then we're also going to hear briefly from Maria. We've asked Maria to join us as one of our valued community partners at Healthwatch. And just recently, they reached out to their members to hear experiences about current service provision. We really recognise that the work that we did, actually, the hub came with us on a journey as well to work and develop the way that they did their work. So bringing in some more recent snapshot views of that service now we thought would be a good addition to the information that we're bringing. And then I'll wrap up at the end to sort of just bring it together and bring it back to what we're asking the board to consider today. Thank you.
First slide, please. Thank you. So the purpose of this work was to understand the experience and the support needs of people living with long COVID in Sheffield. One of the main drivers, as Lucy just outlined, was the fact that despite being disproportionately affected in the pandemic, people from Black, Asian, minoritized ethnic groups were underrepresented in services for people with long COVID. So this piece of work therefore speaks to both the health inequalities that Fatima so well spoke in the previous item, as well as long COVID. So I'm going to outline the process that we went through in the project and some of the findings. The full findings are in the report that I've put out on the tables for you. It's a lot of data, it's a lot of findings, so I'm just going to be quite brief with it for today. Really importantly, the project went through a process. It started with a steering group that was multi-agency, but most importantly, had people with long COVID at the centre of the work. The steering group stayed with the project for the full 2 years and actually came full circle and is now part of the long COVID network, which is a legacy of the project, which I'll just tell you a bit about in a bit. The project worked with community groups through a grants programme, a 3-part grants programme. We worked with 15 community organisations, the first part of which we asked them to go out and research what was happening with long COVID in the communities. And they did that and came back, having spoken to 440 people in the communities, to present their findings at a citywide workshop at which the discussion was generated, the project was fully developed, and collaborations between groups took place. Out of that work, we developed 21 different resources in the communities for people with long COVID in a variety of formats. And then the third part was to share those resources. Those resources reached approximately 20,000 people living in Sheffield. So the grants programme was a really excellent way of ensuring that the resources that we developed were relevant and effective for the communities that we worked with and the communities that weren't being represented in long COVID services. It was both educational for the communities taking part in the process and a functional, obviously, undertaking for people. Sorry, we need the next slide. Thank you. So, alongside this grants process, we developed events and information sessions that marked particular stages in the project. We took almost like public information, health information out to the communities. We involved the long COVID rehabilitation hub who came with us at some of these events. We also, in addition to the grants programme, interviewed 21 people living with long COVID, all of which data is in the report, and the legacy of which has been a really strong long COVID network that has carried on the work of the project, a peer support project that was set up in Fairvale, There was already an existing one in Darnall, so we complemented it with one on the other side of the city. And 21 resources available for communities about long COVID that are all available on the Healthwatch website. So that was the process of the project. The findings were really varied and quite lengthy. So I'm going to try to summarise some of them. People told us that they were impacted, that long COVID had impacted their lives in various ways. Firstly, their mental and physical health. So people told us that long COVID made their existing mental health difficulties worse, or that they had mental distress caused by long COVID. They also had told us about their physical symptoms such as brain fog, fatigue, post-exertional malaise. They told us about how these symptoms affected their work and their finances, so their ability to carry out the work and the impact that this had on their personal and professional identities. They also spoke of the challenges of being out of work and having to apply for benefits. They told us about the impact on their relationships and their social life, their strain on their marriages, their partnerships, their friendships, and their family dynamics. We also spoke to people who were caring for people with long COVID. They spoke of the isolation and the lack of support networks. And throughout the report are the instances of the inequalities in all of these areas, of inequalities of race and ethnicity, and of, for example, a carer with a learning disability who found it hard to get health professionals to listen to her and take her seriously. For those that spoke of their experiences of care, move on to the next, thank you. These can be divided into those that are systemic difficulties, such as not being able to get an appointment and the difficulties that people find in having to navigate the complex systems and the complex referral processes, for example. But a further concerns those experiences that made individuals feel like they had to battle to be heard. So people reporting dismissal of their symptoms and of disbelief, being told that there's nothing that can be done to help them, people that have to self-advocate to be heard. This, people said, is exhausting, and it's also not something that everybody can do. Just yesterday we spoke to somebody who was telling us about a member of their peer support in Darnall, long COVID peer support group, who is still not getting through to the long COVID rehabilitation hub because their GP refuses to make that referral. So in terms of the barriers to support, again, the report is littered with the community examples of what those barriers look like for them. But primarily, the community partners of the project spoke of the lack of information and awareness, of some very basic difficulties that you'd have thought would be over by now, but things like languages and digital barriers, but also a pre-existing lack of trust in treatments and services, all of which were reinforced through the traumatic experiences that many of our communities experienced during the pandemic.
So in terms of, apologies. So in terms of what's needed, I think one of the headlines is really about knowledge, information, and people's understanding of the condition. And by that, we mean both the public, but also within health professionals, and particularly within primary care, where, as we've heard, people are getting really a variable response and not always managing to reach the support that they need. People need care and support where they feel believed and understood and where there is trust. It needs to be person-centred, coordinated, and care which doesn't place the burden on them to chase referrals, navigate services and constantly advocate for themselves in the way that Natasha has described. And they need to feel safe. We heard how people don't always feel safe in health settings because of the infection risk, and I know we touched on that earlier today in the public questions, but I think, you know, we come back around to that reality that for people living with long COVID, they don't feel safe in the current provisions that are made, and that's where we are. There'll be people that are avoiding some appointments because of that. So what do we do with that? And beyond physical health, there's really clearly a need for broader support around finance, employment, and also mental health, where again people face difficulties getting what they needed. I'm going to hand over to Maria for the information that they got from their members.
Thank you. I've been told I've got about 20 seconds for each slide. If I'm speaking really fast, that's why. So I will whiz through, and really, I do feel kind of encouraged that there'll be further conversations now actually about partnership working and taking this forward meaningfully and involving people. Not everybody shares that optimism, but I'm going to start off there. So I would like to thank firstly Natasha and Lucy, Healthwatch and VAS for their ongoing and actually genuine involvement of community groups and of our group at the Sheffield ME Fibromyalgia and Long COVID group. That's been really valued, and your support and collaboration has been really important. So we do support people with all the conditions I've mentioned, and we've seen how debilitating long COVID can be and continues to be, and Fran articulated that wonderfully. When there was uncertainty kind of heard on the grapevine last year about the long COVID hub's funding, we asked members for their views, and I'm going to just run through very quickly some of those responses, and we did get a mixed response. So on the positive side, we heard that the hub has provided emotional support and validation, sometimes leading to specialist referrals and diagnoses, and it helped stabilise symptoms, allowing people to return to work, some people to return to part-time work and establish routines. The hub's support with pacing, phased returns to work and symptom management has been essential for some, and many needed fewer GP visits due to thorough consultations at the hub. Next slide, please. However, we've also heard concerns. So, as Fran touched on and others in public questions, people with severe symptoms, particularly debilitating fatigue, felt unsupported. Some found stress management techniques ineffective for physical symptoms, and others just simply felt fobbed off with general advice. And there were also issues, as we've heard repeatedly, with GPs being uninformed about a lack of diagnostic tests, or even kind of making that connection to the hub and referring people on. Some members felt that without the hub, next slide please, that there would be simply no specialist provision for people with long COVID in Sheffield, and they believe that removing the hub would likely increase GP visits and mental health struggles, as there are no other services that offer this level of support. We believe as a charity that lived experience should help shape services, and by working together, that's health professionals, patients and the community, we can work to ensure Sheffield continues to offer the right support for people living with long COVID and those that support them. Thank you. Final slide, thank you. So in terms of what we're asking the board for today, really it's to take the work that's been done and to really understand it and build on it to take this forward. So promoting public information and awareness is key. Improving COVID safety measures in healthcare settings we've already mentioned. We've mentioned the need to increase knowledge and capacity in primary care. And also there was a specific recommendation in the report which was directed to the Health and Wellbeing Board, which was around work with employers to develop and implement good practice. And whilst that was in relation to long COVID, I think more broadly long-term conditions as a wider spectrum would benefit from a real focus in terms of supporting employers to do better in that area.
But then finally, we really want to ensure that we're building on the insights and the community connections which came from this project. And Natasha's spoken about the legacy of the Long COVID Network. You've got 2 peer support groups in Darnall and Furvow. You've got the group that Maria's here to represent today. There are lots of people in this city who are committed and invested to supporting us to work collaboratively and develop a better approach for people living with this condition. So I guess the final overarching ask really is to commit to actively involving people with long COVID and communities in designing any new service model and approach to supporting people with long COVID in the city. Thank you.
Thank you. Are there any questions, comments that people want to... Greg?
Thanks, team. That was really powerful, particularly the testimony at the start, kind of really statement of the obvious, but it was. The report was excellent. It's a really, really good write-up of a well co-produced model of care with a blend of biomedical, psychosocial, all that kind of stuff. I think it was a decent service, notwithstanding the what's the future conversation we had at the start of the meeting. Would agree with the recommendations. I wonder whether or not we've got the right focal points to ensure that their implementation. I don't know that, but they agree with the recommendations. I worry about that and who's going to do what next bit. We need to come back to that. Ditto the ask on the board per se. 100% agree with regard to the ask on employers. I will do that. Just mindful that when folk ask the board to do something, it's basically me and Dan and all that kind of. There isn't a sort of a management infrastructure around it. Yes, definitely agree, but with the caveat, there isn't really anybody that is the board other than the people that turn up to the meetings and they have to commit to doing the things that are in the recommendations if the board agree.
Can I just come in on that? Because I think what we can do, I mean, there are, including the council, the hospital trust, the care trust, there are some big employers in the room represented. So we could start from our own, couldn't we? And could see what are we actually doing. I had written down that was my kind of 2 pence of contribution to this. It's like we could start asking ourselves as, the police, the university, Hallam University, what are we actually doing to support our own employees that might suffer from long COVID or any other debilitating illnesses? Lee wanted to come in.
Hi, thank you. Yeah, it was, as Greg says, a really powerful presentation, really great report, so thank you for that. Listening to Fran, so who was speaking, she replicated, no one is exactly the same, but replicated a patient that I've looked after for a long time, who doesn't have long COVID, but does have a diagnosis of ME/CFS. So there's a lot of overlap between this and lots of other long-term conditions, which I think is what the point you're making, Lucy, is actually there's a lot to learn from this in terms of how we manage all long-term conditions. And I suppose my only slight concern was the comment that was made in the video about this is a biological illness. And I thought, the one sliver of hope in this is a condition that is occurring and we're discovering at a point in medicine where we understand the mistakes we've made in the past in terms of thinking of biological illness, disease-specific, instead of, and lots of medicalisation, sometimes to the benefit, sometimes to the harm of people. And what we understand now is actually you cannot remove body from mind or mind from body. They are intrinsically interlinked, whether we're talking about type 2 diabetes, whether we're talking about cardiovascular disease, whether we're talking about eczema. We are whole people. That's not to say that we don't understand the biological mechanisms that sit behind a lot of these things. Sometimes we don't. What's important is managing the symptoms and how people are day by day. And I understand where it's coming from because it is so difficult. If you have got an extremely debilitating disease that has fluctuating symptoms, and sometimes you might look okay, the next day you might be bedridden, but there's no test to prove it. I understand where people are coming from going, I'm not sure I'm believed. And sadly, it seems to be that sometimes people are reporting that they're not believed. But nonetheless, this is a profoundly debilitating condition. But we don't want to just look at it in isolation in terms of the biological condition. I think, these days in medicine, we can increasingly know the importance of looking at the whole person and treating people's symptoms and the whole self. That's all I would say.
Can I take the next few people? I have Sarah and Megan. I am going to allow someone, is it Carolyn? Yeah, you will need to come to a microphone.
Thank you. I just want to make a very, very brief point because I realise I'm disturbing your agenda. I think the last comments have kind of highlighted what we've been facing as a community living with people. I'm a carer for somebody who's been ill very, very long term with ME. But one of the things that we face is we've been talking for many, many years about the biopsychosocial model of ill health. And while in theory we would be very comfortable with that, the reality is that all the investment in research, all the investment in services over the last 30 years that I've been around this illness have all been very much focused on the psychological and psychiatric services. So we need to address that balance. There may be, in the future, in the distant future, we may understand much better the mind and body relationship. But for the time being, we have emerging research showing that ME and potentially long COVID are related to genetic factors, that there's immunology that needs to be involved. And by constantly saying we don't understand the mind-body bit of this illness, we have ended up with an ME service for a physical illness that is located in the Mental Health Trust. And that is what's led to all the stigma, and that's what's leading to just the injustices faced by people living with these illnesses. So I'm really sorry, I cannot accept what you've said, and I can give you a lot of scientists who will disagree with you very strongly. So thank you.
Thank you. I'm not going to have, I'm not going to have a debate about this because we could spend a whole week and do a conference on this. So I'm going to take Sarah and Megan, and then I'm going to give and Zach. I'm going to take all those of three, then come back to you and draw it to a close. Thank you.
Thank you. And first of all, just wanted to thank you for bringing the report and for Maria bringing that bit of an update since the report was drafted. I think we mentioned at the beginning that this originally started as a bit of a collaboratively commissioned piece of work to ask some really big questions in a really evolving space and making sure we had people's lived experience right at the heart of how those services developed and how we learned from them. So it's really great to see that here. And I think that's probably one of the overarching learnings we can take that's not specific to this service, but actually what does that collaborative, community-based approach to learning and reflecting and building a service together really look like? I'm conscious there are a few recommendations in there specific for us. I thought it was maybe helpful just to reflect back on some of those, because actually I think we've made some progress since then in light of the things that you've shared. So you've mentioned on the resources to help people access and understand some of the services, the specific offerings within the service, and that's something that the Hub has progressed since that recommendation, informed by a lot of the insight that you've shared. So we're really grateful for that. There's also the suggestion around a self-referral option, which I think is quite a complicated one, or a lot of our long-term condition management happens through that really specialist, expert in-depth conversation that happens with general practitioners to understand people and make sure we're sending them in the right place at the right time. And Anthony might have more to say on that, but I think that is a really important part of our model of care more generally, that holistic, person-centred conversation that happens in primary care helps us make sure people get to the right place the first time, and it might not necessarily always be the long COVID hub as the first port of call if there are other symptoms that people are presenting with that we think are better managed elsewhere. So really recognise the root of that, given the barriers we've mentioned around access, but I think there's a really important principle about making that process work as effectively as it should and does in other pathways for some of the symptoms we've described here. I think there's a couple of other recommendations as well around how we do more on the community outreach and involve the public and patients going forward. I think that's really connected to the conversation we had at the beginning of today's meeting about where do we go next and what does that look like. And then on the final one around support for benefits and employment, I think there is already an offer that the Hub make and could well be in light of some of the recommendations you've had here to give people specific, more detailed letters they can share with employers to help them understand symptom management and how they can best wrap support around people in an employment context. And clearly there's learning from that around, well, how then do employers listen to that and act on it? But I think we really recognise that the value of having some of that more in-depth explanation from a clinical perspective to give people advice and therapeutically what might help them in other settings and in a work setting in particular. So I guess thank you in brief for the report. Thank you for informing some of the next steps that we've taken as a result of that. And I think there is a wider lesson for us about the model that's been described and how we've done the evaluation and supported ongoing development of services.
Thank you. Thank you for this report. I think it's excellent, and massive thank you to the people with lived experience who've contributed to it, because I think that's really incredibly brave of them. I wanted to pick up a couple of points about the recommendation around employment and around engaging employers, because I think, Chair, you're absolutely right about there's some big employers around the table that need to sort of start with their own practices, but I also think that there's a massive opportunity coming with the city being a trailblazer city and the massive investment that's coming in around employment and employment support. And we deliver employment support, but we can't do that well without good job opportunities that are flexible and that are accommodating of people with long-term conditions. So I think that there's more that we need to do, as well as just looking at ourselves as employers around how we influence the private sector and what connections we might be able to make there with that kind of investment that's coming in and how we can influence that. I think some of that investment is coming through SIMCA, or a lot of it is coming through SIMCA, through the Combined Mayoral Authority. So it's about how do we have that conversation, how do we bring this report there as well, I think.
Yeah, thank you. So thank you for the report. I mean, really helpful. I think it's just an honest reflection as a clinician. So if I revert into being a clinician again, which is probably my comfort zone if I'm honest about it, it's that bit about the demedicalisation, medicalisation. I mean, it's a bit I've struggled with for 30 odd years and probably failed to get the answer, because there probably isn't an answer if I'm brutally honest about it. I think it's to come back to the comment Lee made. I remember a patient going back 30 years that went from being a school teacher who worked, who sailed, who did loads of activities, and basically woke up one morning and was bedbound. And at that time, it's probably an old-fashioned term. It was Guillain-Barré syndrome, which was probably a form of ME, but it was extreme. I mean, it was literally, respirator and going from being totally independent to totally disabled. So, I mean, that was an early introduction for me when I was only in general practice for probably 6 months. I looked after that patient for nearly 20 years, working with a really good team, but we didn't actually get him better. And I think that's the brutal reality of some of this. The bit around the medicalisation, demedicalisation bit is, where do you go with it? I mean, the medicalisation bit is very expensive. So is the medicalisation bit to get the diagnosis, but also part of it is to keep up to date with any treatments that are available. And how do you balance that extreme expense with actually, for that small bit of that expense, you can get a lot of support in the demedicalised part of the system? How do you support people? At what point do you accept that actually you've probably gone as far as you can with the treatment bit for the time being, but also keep the doors open for any new treatments that come along? But then how do you do the research? How do you fund the research? And that comes back to the big question about is, how do you fund it within the NHS? So the NHS is broken. There are different views to it. I would argue it's broken because we lost that balance between demedicalisation and medicalisation over the last 14 or 15 years. We've invested more in the medicalised part of it. That is good when it comes to some of the research type bit, I get that. But actually, if you lose that supportive bit in the community, that is a massive issue. So how do you fix it? And the problem we've got, and it's back to that, is there enough money in the NHS? There's lots of money in the NHS. A lot of the money sits in the wrong parts of the system. A lot of the money sits in the medicalised part of the system, but actually more of it in the demedicalised bit could actually have a bigger gain for the population. How do you then balance that between individual conditions and the whole population that we have to look after? And that's the bit that I'm really interested. So just to make an offer, I mean, you know, we had the conversation, brief conversation earlier, largely question driven. I would be keen to take some of it further. So I'm going to make an offer. I'm going to offer on behalf of Lee as well. So Lee, myself, Andrew McGinty, who's our long-term condition lead, who's got much more knowledge than I have, I'd be really keen for maybe following up the conversation. So if you want to get the group that came today together in a slightly wider group, probably easier to do it over Teams because we can get people together quite easily. Let's try and bounce some of that stuff around. And, you know, I'm not saying that any of us, I mean, I know I've not got the answer, so I'll be brutally honest about it. Let's have some of the conversation. But I think we've also got to take it the context of how do we free up the resource that is sitting within the NHS, because there isn't going to be any more money. What we've got to do is get really much smarter in how we use the money. My personal view is that needs to be more towards the demedicalised side. That's very different than when I first started in general practice. And I was naive enough to think there was a magic pill out there that made everybody better. It was quite a sort of a drop to the floor quite quickly to realise that isn't the reality. So maybe have a further conversation if people are up for it. I mean, my contact details, we've got them. I think, Maria, you've got my contact details from the Talbot trustees. So if you want to have a further conversation, let's set something up and let's just sort of knock it around and just see if we can get anything from it.
Thank you. I will have Kate and then I'll give it back to you. Is that okay? Just to get...
Yeah, thank you. Can you turn your mic off there? Thanks. Cheers. Hi everybody. Apologies for being late. Kate Josephs, Chief Executive, Sheffield City Council. I just wanted to pick up on both Sarah and Megan's points around the central part that work and good work and employment and sensitive, informed employers can play in this, both in this issue and in many others. This board has heard an update a little while ago about the absolute centrality of good work to health and well-being. And to just provide some reassurance and make that link, as Megan said, we've got a huge investment coming into our region and into our city. As of the 1st of April, which is next week, Sheffield City Council supported at risk the provision of support for those both experiencing economic inactivity and at risk through the Pathways to Work programme. And just to provide some reassurance, the South Yorkshire Combined Authorities were a huge part of it. We are South Yorkshire here in the city. I co-chair the strategic oversight group for that entire programme across South Yorkshire, working alongside Gavin from the ICB and supporting Sir Steve, the Chief Exec of Barnsley Local Authority. So just to give some reassurance, there's a real opportunity there for us to work in a different way. And what we've seen that's been really encouraging through that programme is a willingness to accept and understand that actually we need employers, the health system, the wider system beyond the NHS, and most importantly our voluntary community, faith and social enterprise sector, all working in partnership to support communities and individuals with a very person-centred approach. And in the current context, that's really, really important. So I think it would be worth this board asking for an update on that. And I think some of the threads of themes that have come out of specific conversations like today's around long COVID would be really, it would be really good to feed those into the work around Pathways to Work, because they are human beings, but they're also really important test cases, because if this is going to work, if we're going to get more people able to stay in work for longer and more people able to come back into good balanced work that works for them, then we need to understand how that might work for a number of these people. Thank you.
Thank you. So are we saying that we're going to get an update to this board at some point in the... Yeah. Could we ask, are people happy with that? Maybe like in 6 months' time, just to give it a bit of time to embed. Brilliant. I'll give it back to you. We're over the 30 minutes, but go for it.
I know, apologies. I have just got a quick comment to round up, but I'm really conscious that Iolanthe is here, and I think if we just got 2 minutes to give to Iolanthe before I make a final wrap-up comment. Thank you.
Hi, I'll try and be really quick. So I'm Anthony Fowler, I'm a GP and I'm Clinical Director at Sheffield Teaching Hospitals, and the Long COVID Hub sits within my services, so that's why I'm here. I suppose there's so much that I want to respond to and there isn't time, but what I just wanted to point out, I suppose at this point, is that the Long COVID Hub has iterated through the years that it has existed, and it's a really agile beast. So we iterate as we get feedback, almost kind of minute by minute, and the staff have been all trained in person-centred, what matters to you approaches, and I think this is what makes it an absolute flagship service for me. I'm not saying we've got it perfect, we haven't, that's why we're iterating, we're learning all the time, we're making the most of the partnerships that we've got, and looking for new partnerships. For example, as Kate was talking about, the kind of investment in work, we are working really hard to think about how we can link with employers in a really supportive way, not disempowering the people that are coming through the services, but helping them to get the assistance that matters to them to be as well as they can and go back to their jobs or look for new opportunities. So in terms of why is it flagship? It's flagship because it is looking at a chronic disease in a really different way, and the central question is what matters to you as people come into the service. And then we're wrapping round, yes, the medical help, so we're looking at the symptoms that people are coming in with, the symptoms that are bothering them most, and we're putting together programmes delivered by the hub staff, but also connecting into other specialist services to address those symptoms. But we're absolutely offering the psychological support, the one-to-one continuity with therapists, and yes, we still have medical support, and we're involved in trials into long COVID, so the research bit is covered off as well. I think I probably need to stop now, but there's loads that we're doing that I think we could learn from in terms of how we deal with other chronic diseases. Thanks.
I'll make it very quick, I suppose. It's just to thank Zach and others for the recognition that actually this is really hard, and I don't think any one person in this room has got all of the answers, which is why the kind of overarching ask that we brought today was about a collaborative approach to next steps. So thank you, Zach, for that offer, and happily we'll set up another meeting to look at how that can be done to involve us, but also people and communities in the next stages. Thank you.
Thank you. So I assume that we are taking the recommendations, and we've already made connections. So thank you very much. And we are moving on to item 8 on the agenda, which is the SEND Manifesto on Healthy Child Development. We are running slightly late, so after this item we will have like a 3 to 5 minutes break and then start again. Thank you. Could you briefly introduce yourselves and just take it away? Thank you.
Hi everybody, I'm Beth Plant, Health Improvement Principal in the Public Health and Integrated Commissioning Directorate here at Sheffield City Council.
Stephen Betts from Learn Sheffield.
Thanks everybody. What I'm hoping to do this afternoon with Stephen is to give you a description of some work that we are taking forward around the SEND Manifesto. What we aim to do to start with is just to give you a little introduction into where the work fits in the context of the Fair and Healthy Sheffield plan. And then also Stephen's going to talk through the SEND Manifesto detail. And then I'll finish at the end of the presentation with some description around what work we are progressing around healthy child development, the outcomes and the intentions for the work, give you a brief description of who is involved in the delivery of the work, and then sum up with some recommendations and some asks of the Health and Wellbeing Board. That's okay. So just to start with, in terms of where the work fits alongside our Fair and Healthy Sheffield plan, of course it's around children and young people, so it very clearly fits under the building block of giving every child the best start in life. But we also have some significant elements of the work that fit within the radical shifts, those being around leadership and workforce, because we hope that when we complete the work, it will result with some key changes around workforce development and training. Also, the work is very collaborative. It's quite a new and different approach to taking forward partnership working. So there is quite a lot of emphasis on collaboration. Again, one of the radical shifts of the plan. And we do think and hope that through finalising the work that it will have a shift around monitoring and accountability across our partnerships, bringing agencies and partners together to work in a more collaborative way to ensure that we own and really push for change to ensure that children have the best start in life. So that's how it fits within the context of the Fair and Healthy Sheffield plan. Stephen's just going to talk about the manifesto next.
Okay, so if we can go through the slides, we'll go fairly briskly because I'm conscious of time and so on. So I've included a slide about Learn Sheffield because I'm conscious that within the room there'll be colleagues who know everything about Learn Sheffield and colleagues who are less familiar. I'm not particularly proposing to talk about it, but it gives you a bit of background to the organisation to come back to later if that's helpful. Okay, thank you. So in terms of the SEND manifesto, so Learn Sheffield's been commissioned by the City Council on behalf of the local area partnership to develop the future strategy in relation to SEND and inclusion. So that's the piece of work that we're undertaking. It's the forward-looking piece of work about what we want this to look like in the future. It's definitely a piece of work where we are developing strategy and delivery at the same time. So colleagues are fond of describing it as rebuilding the plane whilst flying it, and it definitely is one of those kind of pieces of work. I think what I would say to you as a board is the absolute underpinning principle of this being successful is to achieve a genuine shared accountability between education, health and care. That's the piece of work. This can't succeed without that, and a lot of the work we've done so far has been kind of starting to build the things that we need for that. The piece of work is called Better Lives for Sheffield Children with Additional Needs, and it's been described as a manifesto, which is a deliberate language choice. Partly I couldn't bear the idea of developing a strategy because we have a lot of strategies. I think this will, though, inform, in the end, the inclusion and SEND strategy for Sheffield. But the choice of manifesto was deliberate in terms of wanting to catch attention, wanting to signal a change of approach. Sorry, if we just go back one, sorry, I've sort of got a couple bit more to do. So I think in terms of the overall approach, there's a lot of stuff starting to come out nationally and regionally about SEND. You'll be very familiar with the narrative that SEND is broken, and that narrative exists because that's true, but we're very keen to move past that narrative and into a space where we're talking about how to do this differently. Our observation would be that if we think about this piece of work as fixing SEND in inverted commas, although I don't really like that phrase, and we think about this as doing the things that will enable less young people to need something additional and different, those two things are connected and essential. Most of what we're seeing in the policy landscape is the first part. It's technical, it's about how we're going to change SEND processes, SEND procedures, and that needs to happen, but the manifesto is based on the principle that you also need to do those things. That will mean that less young people need something additional and different. Otherwise, we're just building lanes on a motorway, you know, in that kind of classic analogy. So we're talking about that. The other thing I would say is quite a kind of key element of this is we've taken a building blocks approach. So what we're going to do in the slides today is just highlight a small number of those building blocks projects so you can understand how we're managing that difference between developing a strategy and doing some of the work at the moment. So the building blocks are deliberately chosen to be pieces of work that will inform the strategy eventually, but are key to developing our understanding and putting us into a place to then move forward. And so we'll draw attention to a couple of those. In terms of timescale, the approach is that we will The manifesto will start to inform a strategy later on this summer, so sort of June time, July time, and the strategy will be in place from September of this year. Okay, so that's the kind of timeline to the piece of work, and it started in September, so we're kind of sort of 2/3 of the way through it with my school leader head on of thinking of the world in terms. Thank you. Can I have the next slide? Oh, I didn't say this, I will, sorry, Greg's smiling because he knew what I was going to say and then I didn't say it. Please do read the paper and absorb yourself in the SEND manifesto, but if you do just one thing, click on the link and watch the Harry Burns TED Talk. A lot of you probably in the room will have watched it already. But that approach to understanding that wellness is not the same as the absence of illness is really key to the way that we're approaching this work, and he says it a lot better than I can. Okay, thank you. So the core analysis of the manifesto are the kind of following things really. So firstly, children's experiences and outcomes are the product of our collective actions. So what that means is it cannot be okay for different bits of the system to be fantastic and other bits of the system to be really poor. Children, that's not how we achieve what we need to achieve. So there has to be a collaborative approach and we have to get that joint accountability in that space. Small problems become big problems. I imagine that's true of most of the things that arrive on your agenda at this board, but it's absolutely key in the SEND space. Everything that we can do upstream is clearly going to be more effective, is going to make more difference to young people and their outcomes, and also is going to be better value for money. So across the SEND landscape, a clear understanding that small problems become big problems is crucial to how we understand all of those things. Not having your needs met is not a neutral thing. So if we're not capable of meeting your needs, you aren't sitting there in a stasis, you're collecting difficult and negative experiences, and your difficulties, your challenges, the things that you're trying to deal with are getting more difficult and more challenging. They're not necessarily just staying the same. So it's a key part of how we're thinking about it. Growing up's changed and we haven't kept up. I say that as an educator. I imagine it's true across other disciplines. We'd only have to talk about speech and language and the way that young people experience technology and the impact that has on the way that they develop language to sort of see obvious examples of that. But across this space, that is a kind of key element. We work in an almost entirely reactive paradigm in SEND. So if we were to look at the whole SEND system and divide it into reactive and proactive, almost all of it would sit in the reactive, which effectively means that what we have is a kind of fail-first approach. I know that's not uncommon across a lot of systems, and there are reasons why, obviously, that's true in this space, but we need to do more things further upstream and in a more constructive way. You'll have read in the paper we talk a lot about growing and mobilising the forms of capital that we need in the system. So our observation would be we need to grow our intellectual capital, as in the things we know and understand, our organisational capacity, capital, as in our ability to get things done, and we need to grow our social capital, as in our ability to build trusting relationships and work together. Those things, in our view, don't happen by accident. Those things don't just occur. You have to consciously grow that. So when this comes back to you at later stages, you might well find that a lot of the way we're describing the strategy is in terms of how we will continue to grow those forms of capital and how we'll mobilise them and move them about. Referring back to the comment at the beginning about we have some extraordinary practice in Sheffield and we have some practice that we would like to be a lot better. What we're not good at, I think a lot of the time, is mobilising the strongest practice and enabling it to impact more widely. And then lastly, and this is a kind of exercise in politeness really, unreformed, the SEND system has, brackets, will become totally unmanageable. I think you wouldn't find too many people at the front end of the SEND system who would regard it as a future thing, that this will become unmanageable. It is unmanageable now. It's extremely difficult. Thank you. So I'm just going to give very quickly, between us going to talk about 5 of the building blocks, just to give you a sense of the work and a sense of how we're managing that tension between developing strategy and the building blocks within that. So this first piece of work's around resource provision. So by resource provision, we're thinking about integrated resources in schools, which is a situation where the young person is placed and funded specifically for that provision. But we're also talking about what colleagues would talk about as hub provision. In other words, the school has organised its resources in a way to try and meet the needs of a group of young people that they are struggling to meet the needs of in the normal kind of classroom situation. The piece of work here grew out of some work that we've been doing with integrated resource leaders, and basically we developed a set of quality standards which you can access via the Learn Sheffield website. So the quality standards are a description of what we think a quality resource provision looks like. So it's a developmental piece of work. It's not about weighing or measuring those provisions. It's about developing those provisions and having a shared understanding of what high quality looks like. As part of the funding that we've received, we're doing 40 inquiry visits using these standards across this academic year. We're about just over halfway through that now, and we will publish the learning from that, not in a kind of provision A was this and provision B was this kind of a way, but in terms of what we've learned about where it works well, what are those features, where it's more difficult, what are the things that we need to be kind of aware of. We've also done some audit work in this space, so we'll publish that after Easter, and then we'll publish again after the summer. Thank you. Next one, please. The SEND system features you hopefully will have spotted within the 5 pages of the document that are the kind of latest version iteration of the manifesto. Again, that is our take collectively as a senior leader group on what are the features of a successful local area SEND partnership. Some of those features are echoed in kind of regulatory processes, in inspection processes, but there are some things in there, particularly around practice, which from an Ofsted point of view is uninspectable within a SEND inspection, that we think is doable as a partnership and in terms of that. Obviously, the starting point for any kind of improvement is a good quality self-evaluation. You need to understand where you are and what you want to get better at. So we've used this as a group, as a senior leader group to do that, and we will follow that up at the end of April with some SEND inquiry work. So we have a team of maybe 20 or 30 people, I think it will be in the end, from across the education, health and care spectrum, who are doing a range of activities together over 6 days, I think over 2 or 3 weeks, to dive more deeply into some of those issues that we are curious about at this point. Some of that will link to the recent area SEND inspection, which obviously we can't talk about because it's confidential at this point. Next one, please. We've also been working on re-engineering the graduated approach. So the graduated approach is a key part of the SEND system. It's right from the beginning of the SEND system being described in the way it currently is. So way back to sort of 2002 and before, the graduated approach is a kind of key concept. It operates pretty much exclusively as an education concept, although it is meant to be a concept that goes across. The reality of the graduated approach is that it operates as a funding allocation tool. It's very paperwork heavy, not just in Sheffield, but nationally. It doesn't function in the way it was originally described. It was originally described as a dialogic approach. So this is the point of a graduated approach is at the point where we're working with a young person and their family, and we aren't quite sure what's next. We don't quite know enough to know what's next. At that point, it's about accessing the right expert voice, the right expert understanding to be able to kind of move that forward. And it is a plan, do, review cycle. And that's the kind of model of approach. One of the pieces of work we started to do is how we will re-engineer the graduated approach, which is obviously also key to trying to move some of that resource upstream in terms of bringing it to bear at an earlier point. Thank you. Next one is a piece of work called SenseMaker. So we have some public health funding to work with the Cynefin Institute, who've developed a tool called SenseMaker. We're using this in a couple of ways at this point. So just after Easter, we'll use it for the first time with children as part of our SEND inquiry work. It is a different way of trying to capture experience and voice effectively. It's not a kind of Q&A type approach. It has some different features within it. Please don't ask me questions about explaining it because I'm really not clever enough, but very happy to kind of, to give people a chance to have a look at it. What we've committed to do is to use this in relation to SEND, which we'll do next term, to use it in relation to attendance, which obviously is another challenging issue in kind of my part of the world, and then also to come back to the city more civically to talk about whether this might be a tool that's actually useful more widely. Because in the way that we will talk to young people about their experience of growing up in Sheffield, obviously there's a very natural next step, isn't there, to talk to adults about their experience of living in Sheffield. So this may be a useful thing beyond this, but this is our baby steps into using this. And then the last one, which we've deliberately left till the end, because we think it's probably the most exciting, although some of those are quite exciting. I'll pass over to Bethan.
Thanks, Stephen. So I'm just going to talk about the building block that is healthy child development. It is a really innovative, or we feel it is an innovative approach to focus very specifically on developing a Sheffield detailed explanation and I suppose, for want of a better word, definition of what healthy child development is, and for the city to own that. And I'll describe a little bit more detail. So if we just go on to the next slide, please. Thank you. It's a collaborative partnership, and I think firstly, again, I need to thank all partners, particularly those in the room today. So the piece of work has started with really working with Sheffield Children's Hospital, Primary Care, Sheffield University are represented in bringing practitioners, and we have spent a long time thinking about who are the right people to get involved in this work. And we've been able to, fortunately, get some protected time through different professions. So at the moment we've got involved representatives from the Speech and Language Therapy Service at the Children's Hospital, 0 to 19 Healthy Child Programme practitioners, so that's health visitors, school nurse representation. We've also got Child and Adolescent Mental Health Service members and our Parent and Infant Relationship Service, so a real key focus on early help and early intervention. We've got physiotherapy services represented and occupational therapy services represented in the work. Through the education sector, we've got special education need coordinators, head teachers and education psychology services involved, social care, and as I've mentioned, our university partners. What that group of experts are doing is coming together to undertake what we've defined as a writing workshop. And it's been quite interesting actually to get those individuals in a room for a significant period of time to talk about the way in which they each, in their own professional area, assess developmental need, the points and the times in which they work to look at how a child is developing and when they look to notice that something isn't how they would expect it to be. And what is really interesting is they're doing that at very different points, at very different times, which you would expect working independently within their own profession. What has become quite clear from the work is actually there's a great amount of interconnectedness that we can do to clearly define where things aren't going in the way that we would want them to go with regards to a child development at the earliest point. And to do that, we've spent a lot of time working out what are the things that we need to do at the very start of a child's life in terms of assessing their development, and make sure that then we do more of that and work out where the points are that children need that help. We hope that the work will give us an early warning system to help us to identify children's needs and inform strategic planning in the future across education, health and care, so that we are able to commission services maybe in a slightly different way, but also that builds with the work that we've talked about involving the Sense Maker programme, that listens to children and young people's voices as part of the programme of work as well, and delivers that as part of the manifesto. So just to finish, where we've got to with the work, next slide please, is the image is one of a rope that is likely to change, but what we're trying to describe is the different elements of child development that are interconnected. And we've done that through looking at social and emotional development, speech and language and communication, physical development, movement and coordination, and cognitive development, curiosity and creativity. The focus initially for the first tranche of the work has been on perinatal through to age 11, which we're very nearly completing. And then our intention throughout the summer and up to September is to look at teenage and adolescent years. We are hoping to produce both resources that professionals can use, and we will look at an element of training and development through workforce delivery. But I think the most exciting element of the work is that hopefully the outcome of this will be that when we talk about commissioning services, that we commission services that work in a more interconnected way and are joined up together. So our next element of sort of approach with this is to, I think probably further down the line, bring practitioners involved in the work to present how they feel the work has developed and enabled them as practitioners to work more collaboratively. So what we'd ask of the board today is for you to sort of endorse the different approach that we're taking in the SAND manifesto and particularly the healthy child development work. We'd really expect organisations to act consistently with shared accountability and joint strategic planning outlined in the manifesto document. The success and delivery of the healthy child development work really requires the dedicated time from those practitioners that have been involved, and we're very mindful that it is, whilst it being a small number of professionals, it is clearly taking them out of direct work while they're involved in this particular programme. So we'd really welcome our partners to continue to support that, and particularly looking at Yvonne from the Children's Hospital there. And for Health and Wellbeing Board members to sponsor the outcome of the work, we very much hope to have a holistic and connected description of healthy child development that will enable system leaders and organisations to help make better choices and family-centred decisions for children and young people. And we would hope then that that's signed up across the whole city so that education, health and care are all working to actually commission and deliver services that meet those healthy child development descriptors.
Thank you. I'm going to stop there. We've nearly used all of the time that was allocated to the piece. So can I ask people who want to speak to just be really succinct, because so I had Douglas putting his hand up first, Yvonne, and then Greg and Meredith, and Amit Kati, Sarah. Can I take all of those people, but can you be as succinct as possible, please?
That's never easy, is it? I'll try. So first of all, this is exciting, really is. It's exciting, it's called a manifesto, because that tells us it's something a bit different to what council people tend to do. It's saying that the system isn't good enough at the moment, we can do better, and there's a way forward. So that's really encouraging. Let's keep that word in there. Politicians like manifestos, you know, we're meant to believe in them. The other thing is, what's the point I was going to make is that it's really good to sort of just state again and again, you need to bring education and health and social care together. Speaking as chair of housing, I think it's fair to say housing needs to be in there as well, and sort of invitation from me is to make life much more difficult for the staff in my area and say actually be more demanding about the role of housing. And the reason I was thinking about it is because, you know, we all know that it's often said that moving house is one of the most stressful things you go through apart from divorce and Christmas. But actually, no one ever really thinks about what it's like for children moving house. They don't get asked. Probably because the parents are too stressed out and no one else cares. But too often I find that, you know, when we're looking at people who have to move house, people might be in temporary accommodation. That's pretty bad for the child for a start. But people who are in permanent accommodation, if they're being told, right, well, you're going to move somewhere across the city, we have a statement saying that we'll give people as much choice and control over where they live under our location system as possible. We don't do that. And want to push back when I hear our housing staff saying, we can't take account of where your children are at school. We should be. It's incredibly disruptive and damaging, and I'm sure there's a big correlation between a lot of the SEND issues and the way people experience about being moved around the city, and I think that has to change, really. So go back to what I was saying before, we can do better on that. Currently, the Housing Service is consulting on its allocations policy about how people are housed. I'm just going to invite everyone to pitch into that where you can, and if people want to send me comments directly, I'll go and say that these are important things and should be fed in. Sorry, probably not succinct, but there we are, I've said it.
You never are. Yvonne.
I will be. We are a city that are absolutely committed to children and young people, which warms my heart in the job that I do. This is exciting and really innovative, I think, in the way it's been approached. It needs to be done. Something has got to change. My tussle, I guess, is I've got clinical activity which needs to happen, waiting lists versus the benefit of these conversations. We can commit as Sheffield Children's. We are absolutely committed to this, and our colleagues will continue to be available, to be involved. Thank you.
I'll also be succinct. Stellar work. View it as permission to proceed and buy-in from institutions, sectors, actors, etc. Proceed until apprehended. I'll just big up the Harry Burns video. If you haven't seen it, you must watch it. I have never fessed up about this, but an awful lot of our Fair and Healthy Sheffield plan is built upon the principles in that video. So, and that will remain to be the case. Question, don't come back on it now, but give some thought to how we're evaluating both our kind of learning and processes, how we can, maybe some big R research in there too.
Yeah, so this is really brave and courageous stuff that's going on and is absolutely built on strong partnerships. I think that the outcomes, it needs to be that children's opportunities are vastly improved, and that's what we've got to be driving, and this will allow that to happen because we're looking at it from a different context. So I think I'm absolutely supportive of it.
Thank you. Echo others. It sounds like you've started in such a brilliant way and great example of kind of cross-sector working. One thought I had, and I probably would say this, is I'm also interested in at the later stages of that child development, how we start to prepare around transition between children and adult services, and that just feels like we know that's a really challenging time for people. There's work underway already, I think, through the Acute Federation and with the Children and Young People's Alliance, really focused on that and developmentally appropriate healthcare. So it feels like there's some really great threads of things that could come into your rope on the screen there as well that connect into this. So clearly not the focus for this piece of work, but making sure that we don't inadvertently create any bumps in the road later in that pathway for people feels really important. But thanks for sharing today.
Okay, I'll try and hit the bar of succinct as best we can. So I think thinking about housing and also transitions, I suppose my observation would be if we can develop a shared understanding of the things that will make the biggest difference to how young people develop successfully, then actually why would we not? Why would we not use that to inform how we think about housing policy or green space or transport just as much as we would think about it in relation to education, health and care? And I think transition, it will be a really helpful piece of work in terms of transitions. I think it is really innovative. It is an innovative piece of work. One of the things that that draws together a number of those building blocks is that colleagues have started from, we'd like this, and then we've looked and it doesn't exist, so we're creating it, and that's that's kind of the basis of that. Lots of colleagues have said very supportive things about how we go forward. I suppose my observation would be that partnership's really easy till we have to give something up, until we have to do something that isn't in our organisational best interest, but it's in our collective understanding. We've made a really positive start in building social capital, but we've that's years in the making, not 6 months in the making, and so you should hold us to account around that. And then in terms of evaluation, I think I'd say two things. Definitely we should bring in external folk to help us, and as well as within the partnership, to do that research piece. We're working with ISOS to bring some external scrutiny around some of this, which is the organisation that have just published in a few months ago quite a big report in relation to SEND. But I also think that a lot of these building blocks are modelling the behaviours that we want to see. So we're doing the SEND inquiry as an activity at this point, but it won't be a SEND inquiry next year. It will just be our business as usual. It will just be what we do in terms of how are we curious about the impact of what we're doing. We go look, we talk to people, we examine, we build an evidence base upon which to use that for our decision making. So, you know, we're doing it at the moment in terms of building blocks and to do a piece of work, but actually what we're modelling is how we need to work.
Thank you. I'm going to bring that to a close. The recommendations were very kindly read out by Bethan. Are people happy to support those recommendations? Thank you. We're going to have a 3-minute break. Grab a drink, don't chat, and come back. Okay, thank you. We are on item 9 of the agenda. This is the Better Care Fund update, and I have Martin, Paul, and Robin. Thank you.
Thank you, everyone. I'm Martin Smith, Assistant Director of Transformation and Delivery, and look after the Better Care Fund programme on behalf of the Health and Wellbeing Board. I'll pass over to my colleagues to introduce themselves.
Yeah, hi, I'm Paul Higginbottom. I'm the Strategic Commissioning Manager, and I lead currently on the tech and digital transformation.
And I'm Robin Pryor. I'm the Commissioning Officer for Home Care Services.
So we'll make this update as succinct as possible. It's 2 parts. So the first part is the assurance on the Better Care Fund and the Better Care Fund Plan 25-26, and the second part was the transformation part around what we've done with the home care contract, and my colleagues will take you through that. So I will try and be as succinct as possible. Just for the board to be assured, the Q3 update was signed off and submitted on the 14th of February. Sheffield continued to meet all the national conditions set out. In terms of avoidable admissions, we're on track. We thought there would be a larger growth. We had a discussion at the last meeting around long-term conditions. My proposal is to make that the focus of the next Health and Wellbeing Board meeting. Will come with a Q4 end-of-year update with a focus specifically on long-term conditions, looking at the protected characteristics and a delve into that area. In the report, I've detailed, and I've got some here, but I'll just whiz through them, some of the really great work that's happening in the system around this. We've got the spirometry now for more accurate diagnosis mobilised. We're increasing the uptake of pulmonary rehabilitation. Healthwatch have done a report recently to understand why different communities, why people might not be engaging with pulmonary rehabilitation. So we're reviewing that, and we can include that in the next bit. We've got smoking cessation and lung cancer screening for people 55 to 74 who used to smoke. Respiratory leads are looking at those with COVID and flu vaccination uptake. We've got the COPD team and the respiratory mental health teams working collaboratively in an MDT to ensure that people with these conditions are being managed, they're accessing the right services, they've got the services they need. And as I say, I've put quite a substantive update in the report around all the things we're doing around long-term conditions, but the Q4 will be even more. Discharge, still on track, 98% of people being discharged home from hospital. We did an update at the Healthcare Partnership on discharge, and also at the Adult Social Care Committee there was a paper this week on discharge. I've included the link in the paper about all those details, but effectively we've got a joint discharge lead. We've operationalised a digital discharge tool. We've got a care transfer hub. We've been focusing a lot on the discharge pathways, simple ones, and we've made significant impact on discharges that we call pathway 3, which are those people that go into residential care or our model, and we've reduced the number of those people going. Supported by the home care, you'll hear about that after this. We're slightly off track with what we planned for around our residential admissions per 100,000. Now this could be like the data coming back to what it was through COVID. We're still significantly better than core cities. Again, the care and wellbeing contract you hear about supports people at home. Again, in the paper, I've put all the stuff we're doing around supporting people to stay independent at home and not go into residential care too early. We had a deep dive of falls and all the falls collaborative work that happens slightly off on the plan. We did have an aspirational plan around this, but in Q3 there were 114 citywide care alarm attendances from YAS calls, stopping people going in. There's lots of good collaborative work on that area still continuing. In terms of the Q3 finance, we are overspent on that element of the budget that we originally spent, but the Better Care Fund budgets are a subset, so they don't reflect the totality of the budgets for each organisation. The main cost pressures in there are around out of area placements, more acuity, and each organisation's got plans to bring those back in line. The paper also just has an update on the Section 75 review that we had a mandate to review through the Health and Wellbeing Board, just to say all the areas in the Better Care Fund have been reviewed. We've identified those through our Joint Efficiency Group and through our Executive Senior Group, where we need to do a bit of a deep dive on, understand the service, and there's a lot of service transformation and rescoping in there. The discharge fund, as part of the 25-26 refresh of the plan, has been agreed with partners, so it's £11 million worth of funds that come in through the Better Care Fund. It came in as flat cash, so we had £1 million less than last year, so we had to have a good partnership discussion around where that money spent, what the impact of schemes were last year. The main focus has been on community and including the palliative esteem, so mental health and physical health, in terms of how that money's been allocated around partners and the impact, so we can bring back the impact and the measurements of those funds and schemes that were agreed as part of the update at the next board. And finally, the 25-26, the guidance came out late January and the plan needed to be in the end of this month, but it needed to also be aligned with the NHS planning process, which is really just finished. So given the really, really tight timeframes, we proposed pretty much a rollover of the plan with the schemes as we're making good impacts already. The metrics have been agreed through the relevant discharge boards. The metrics have changed slightly, so long-term conditions and falls have been taken out, but we're proposing to keep those in. They've moved to 65 plus emergency admissions just as a general, and expected discharge date and length of time between expected discharge date and when people are discharged in hospital is a new measure that's been added. As I say, the finances for that plan have been agreed, the metrics for that plan have been agreed. The draft plan's been sent to NHS England, had input from partners, and we'll send that plan round today actually, because we've got all the information we need on it, and we're asking for delegated sign-off from the co-chairs of the Health and Wellbeing Board to submit that. The delivery of the plan is where we can really influence, and the board can influence at the next stage. That's all I wanted to say from the governance insurance bit, so I'll pass over to Paul. Thank you.
Okay, thank you, Martin. Okay, so we've run a piece of home care transformation across the city from 2022 through to 2024, and our new care and wellbeing service went live on the 3rd of June 2024. It's been a large piece of transformation. It's gone from having providers, 35 different providers across the city of all different shapes and sizes, carers running all over the city, so some pretty negative outcomes for people. We wanted care workers to spend more time caring. Benefits to the climate, you can see from the map on the screen. We actually moved from 35 providers to 14 providers operating from 16 patches. The key principle of the transformation was that we wanted to put workforce front and centre. It's well documented the challenges that we face in home care in terms of turnover of staff. We wanted to make sure that they were well led and well managed by our new providers, and that they had a conducive working environment. You'll see from the map itself, it's really about home care operating its best in consolidated geographical patches. It allows us to recruit more home care workers on foot, which is a big benefit for us. It also makes services more resilient in bad weather. Our workforce development team at Sheffield City Council has stepped forwards, and we've got a joint workforce development plan with those 14 commissioned providers. So 2 providers operate in 2 patches. Okay. We were really keen to move to a strong voice for people in receipt of care, so we could really get their knowledge and experience of the care they were receiving, so we could help inform continual service improvement. It's very much based on strength-based as a part of our approach in the city, and we were wanting to make sure that we had a digitally mature marketplace. The contracts were based on optimising care for providers so that we had a more sustainable marketplace. So we weren't talking about supersizing provision, we were optimising that provision so we could invest, or the providers could invest with us in a long-term relationship. So the contract was 7 years with an option to extend for a further 3 years. In terms of what we've done, it's very much a neighbourhood-based model. So it's working very closely and it's aligned with our primary care networks. So from the research we did, 51% of the 2,500 people in receipt of home care services also had a live community health care plan. So there was some real crossover there between health and social care. So this model is about working more closely together across health, housing and social care to that single end to give people the best quality of life. We are going to go to London in May. We've been invited by the National Home Care Association to showcase Sheffield's model of care because it's been seen as the best practice across the country. But we are also working on continual transformation. So there are the building blocks you'll see in the slide that when we send it, there's a whole host of work being undertaken, not least the move from time and task to outcome-based service delivery based on what matters to people. That's be done, Angela.
Perfect, both of you. Thank you so much. There are some recommendations which I'll read out. Is there anybody who wants to add anything, ask any questions? Zach.
Sorry, I'll be quick, but no, it was just to thank you. I mean, it's really helpful just to hear what's going on behind the scenes, and I think it's linked to probably some of the further conversations. The bit I'm really interested in, particularly in the territory we're getting into about having to consider some horrendous things to do to the system, is are there easy wins that we can, so how can we stop the patients that don't need to be in hospital from being in hospital and release that cost back into the system? And it's the sort of thing that we're just talking about that I know will do it. I think the issue is how can you then demonstrate that it does it? And some of it is around the ambulatory care sensitive conditions, which I'm a broken record, I keep saying it. The patients are not being admitted because of the conditions largely. They've been admitted with the conditions. And they've been admitted with the conditions because the complex patients hit A&E, being managed quite often perfectly well within the community. But because of the lack of knowledge or understanding, or probably capacity, excess capacity within the community, they end up being admitted into hospital, they decompensate, damages the patient, then costs a huge social care cost when the patient is eventually discharged from hospital. So we're on the right track. We've got all the bits in Sheffield. It's how we actually make the bits really bite. And that is the partnership bit we talk about, the health and care partnership. And it's a partnership, it's not a domination by any single organisation. It's got to be a partnership because that is the biggest opportunity. And it feels as if we're really close with some of this stuff. So thank you. I mean, it's the sort of stuff that really interests me. So it sounds great. It sounds exactly what we need. I think it's trying to demonstrate the effect that it's got in the system that is the key bit.
Thank you. I have a number of people who want to speak. I'll take Douglas and Sarah, then get back to Paul and Martin, and then I will take James, Kate and Alexis in that order.
Thanks. Yeah, just a very quick question. It's about the big changes in the cost of national insurance, the cost of minimum wage, starting from 1st of April, or first week in April. How much is the risk that that's going to sort of cause massive disruption in this sector with things like, well, either the costs or some of the providers it talks about, going out of business? I mean, how much of that is a risk that's been taken into account when planning for this?
Great. Thank you so much for both parts of the report. I've got, I guess on the second part, really positive to hear about the developments that are being made and that national recognition. It's really great to hear about that, and I'd be keen to hear more about the impact we're seeing of some of that consolidation going forward. I think there's lots to learn about what the right footprints are for us to be thinking about in delivering care. So we'd really welcome to have that conversation again as we learn more and go forward. On the first piece about more of the governance side of things, just a couple of points. I think there's probably a reflection, and Martin and I have had some emails about this, on whether we've got all of our governance right for developing some of these plans. I think we've got some groups probably that don't have all the partners in at the moment that are providing different parts of this quite complex system of support. So I wonder if there's an action just to reflect on as we go into next year, if we got the right forums in place to do some of that forward planning and sharing knowledge about where we need to prioritise activity. So perhaps something for us to follow up on outside of the room. And then I was also reflecting on the conversation, the point you made about COPD and some of the work happening there, and it's great to hear that there's more in-depth work looking at some of the barriers to people accessing services. It felt quite noticeable that only 50% of people are, I think you said, participating once referred. And I noticed that the barriers that you mentioned are things like travel, transport, limitations in exercise as a barrier, and thinking about whether we've got the offer right, not just the access into the offer. And it's clearly not just the clinical offer, but those wraparound things around travel and access, which are such cross-cutting themes. Be interested to hear more about how we're tackling some of those going forward. But thank you to both of you for or three of you for the report, really helpful.
Do you want to come back to any of that? I mean, there weren't.
Yeah, can I just sort of defer the question around the cost pressures to Alexis?
Thanks, Paul. So we got so it's a really good question, Douglas. We actually discussed this yesterday at the Adults Health and Care Policy Committee, and there was a particular report set out the uplifts, annual uplifts, but also the impacts of how we ensure market sustainability. And one of the key commitments that we've made is we will continue to go and monitor and work with the care sector to look at what the impacts are beyond April and continue to work on that. And what I would say is that we've been in a very privileged position in Sheffield, is that we've had a very stable market through a lot of the work that we've done through our commissioning team and through working collectively with the care sector across Sheffield. We're actually in one of the unique positions that we've had a very, very stable social care market over the last 2 to 3 years. So we've only had 4 contracts handed back last year. And that's because we work collectively and collaboratively with the care sector, which in the size of Sheffield is actually a very significant statistic. Plus also 86% of our care providers in the city are rated either good or outstanding in terms of care. And finally, what we have done is already embedded a lot of care into multidisciplinary work, and either through discharge or preventative work. And it's a real mismatch between what we've got between private sector, employee-led firms, and also social enterprises and voluntary sector are delivering our care across the city. And we are quite unique in that in different ways as well, which is why we have been highlighted as best national practice. In terms of national insurance, what we will do is continue to monitor the impacts of that in terms of care provision come next year, but also monitor the impacts of our uplifts that's been provided. And, we have made that commitment to working jointly with the care sector from that. And there was also a really helpful debate and discussion yesterday at the Policy Committee, which I think has reinforced that commitment to take that forward.
Thank you. I will take James, Kate and Alexis, do you have to add anything? Did you want to say anything more than that? Do you want to do it now? And then I'll take James and Kate.
So what I want to do is say a massive thank you to the team here, because just in 3 different points here, the work around the care and wellbeing has been a really big piece of work, and what it did was set a foundation for multidisciplinary working. And what we have got through that is really good joined up working across each of the trusts and each of the voluntary sector and kind of primary care. And what we're seeing is some of the care dividends within that. What we see is that we don't have any waits for home care. We have very, very minimal waits for home care now. What we have is actually a good home care offer now in the city. And equally, what has been key from this is actually our focus on workforce development. That has been absolutely core. And I think, so I just want to say a massive thank you to the team. I think also in terms of the discharge element to that the proposals in terms of how we use the discharge funding was really undertaken collectively and collaboratively, and I want to emphasise that, because coming back to your point, we actually did have all the players in the room, because we made sure of that in terms of, so we had each of the trusts represented, as well as key colleagues, and what we made sure, and transparently, there was voluntary sector, healthcare provision, as well as social care provision was part of that, and we made a deliberate and significant investment towards making that shift from acute to community, and equally towards, and particularly towards mental health, because we know that that's the areas in which we need to develop, and it's very much in line with the intentions of the Health and Wellbeing Board that we've set out collectively to go and do. So I would like to see, you know, it's been a really good effort to go and do that, and certainly I can pick up these kind of conversations out with that around here. But I say finally, is I think is some of the reporting that's been undertaken by Martin, if you look at over the last 4 years, which I often sometimes do, is that reflective kind of piece, is actually what we were reporting to 4 years ago to where we are now is significantly different. And I agree with you, Zach, because what I look at the Darcy report, and Sheffield's got every single now condition in place to go and develop that kind of integrated neighbourhood model. That's you know, a lot of these practical developments have laid that very good foundation for going forward.
James?
So, first, I just wanted to touch on some of the same things as Alexis, really, in the sense that I really welcome the focus of the discharge fund for the year ahead on mental health. That is really good for our city. I would also welcome the collaborative approach that's been taken to doing that. We haven't always agreed, have we? You know, there's been some creative tension, but I think that means we're having a real conversation. I think to strengthen that in our delivery in the year ahead, I'd really welcome more VCS input into that as well. I think in terms of the delivery, I think that would add to what we've got. And then turning to the care neighbourhood model, that's great. And there's lots you can connect with there, lots of opportunity for us to do things together. In doing that, which I agree is absolutely the right thing to do, let's not lose sight of communities of interest or particular parts of our community who might not be located in one patch or another. And I know, and you will know, that there are care organisations that particularly seek to serve communities and bring some cultural competence to the table. So I'm sure there will be ways that you can find some innovation in and amongst this model, which is the right approach.
Thank you, Chair. I think I just wanted to, echo Alexis's and everyone else's thanks to the team for all the work here. And particularly, I think there's something really important not to lose sight of, that this, and I know Adult Health and Social Care Committee have discussed this, but in this forum, I think it's important to acknowledge just how important this shift on care and wellbeing is and how much work went into that. It's very classic Sheffield, Paul, to sort of describe this in a really matter-of-fact way. This has taken a huge amount of work, and actually I don't think there's many other places in the country, if any, who've been able to do this in their home care market. That leads me to, I guess, an ask really of you and the team, which is not to lose that learning, because I think from a national point of view, and I was thinking about this watching last night the panorama that was on Monday, where one of these companies was featured in the context of what was discussed earlier, like how do we actually think about our care system as absolutely integrated in the future of, you know, health and wellbeing and the NHS. And so it's really great to see Sheffield and so many aspects of what's happening in Sheffield at SDH, in the care system, highlighted as positives there. I think we just need to make sure we don't lose the learning of how we did this, because I think lots of other places will want to learn from that. And what it does is it creates that foundation that's secure and sustainable, notwithstanding the challenges that Councillor Johnson's flagged, that enables us then to start to layer on sensitively the sorts of points James has made. So I just wanted to say a big thank you, and I did want to sort of slightly abuse the fact I've got the mic to make the comment that this is Alexis's last Health and Wellbeing Board. I think most people are aware that Alexis is moving home to Scotland, and I think there are many things that Alexis has given to this city through her leadership and commitment, but and lots of them people won't see, understand or even know, but this is just one example of the sort of visionary leadership that Alexis has brought to Sheffield. So I did just want to take that moment to say thank you to Alexis. Thank you.
I was going to do that at the end, but thank you. Thank you. And can I add my kind of thanks to the team? And I think it's true we take for granted some of the stuff that we do in Sheffield. And you know, in my time, this is the last Health and Wellbeing Board of the municipal year, and this is my third year. And I have worked in this for 3 years, and the relationships already existed, but they are, you know, they've become much deeper. And how we work, you know, in true partnership, even when we don't agree with each other, but we have that kind of relationship where we can say we don't agree with each other and move on and build on it. And I think it's really important that we don't lose track of what we are learning along the way. So thank you very much for the work. I don't know if you want to come back.
I just want to say a huge thank you for the senior leadership. That's yourself, but with Alexis, time and time again, it's been mentioned in national forums that this would never have happened without that senior leadership. It would have been impossible. So a huge thank you.
Note.
And I just want to come back on the governance point. Totally accept it. We recognise that the schemes in the Better Care Fund are probably outdated now, and we want them to align to the new integrated neighbourhood models, new policy. So we are looking at, I think we've got it right at the top. We've got the executive buy-in, but the delivery groups underneath need a refresh and a look at, and we've got some dates and times in to already do that. So thanks, Sarah.
And just, James, just to come back to what you said about communities of interest, Martin can vouch for the fact that I just last time we had the conversation, I was looking at, I asked for data on communities of interest. So hopefully next time that you come around, I think that's what we've agreed, that we are going to look at data of how different groups and fare in all of this. So the recommendations are to note the assurance provided on the 24-25 Better Care Fund plan and the progress update for Q3, including detailed information on spend and activity data, narrative feedback on local progress, challenges and highlights, and the collaborative work of home care transformation. And number 2, to delegate the Better Care Fund 25-26 plan sign off to the co-chairs of the Health and Wellbeing Board. The plan details the allocation of Better Care Fund funding, including NHS minimum contribution and additional funding for hospital discharge and other integrated care initiatives. And the plan also includes specific metrics and outcomes to measure the effectiveness of the Better Care Fund initiatives, focusing on reducing hospital admission, improving discharge processes, and enhancing overall care quality. Are members happy with those recommendations? Thank you very much. And we have now item 10, that is our Director of Public Health report.
Thanks, Chair. For ease, I'll be very quick. Keep it quick because many of you will hear me drone on about this tomorrow. This is a paper on the Director of Public Health annual report. It's an annual thing I have to do, losing the title. This year's theme is poverty, pretty fundamental determinant of health. The report itself is in the pack, covers 3 things: why it matters, what the stats tell us on poverty per se, and then the health impact of that. And I draw your attention specifically to the graph on page 101, which is the 30-year look at the health impact cut by income. NB, there is small print to that graph, but it's a really, really powerful graph. And then thirdly, what to do. Refuse to accept status quo, commits to a refreshed action plan across the city, shaped by a set of principles, and in all of that there's a very strong commitment to us being mindful of our narrative and the stigma that goes with poverty. As I say, many of you will have to listen to me and others drone on tomorrow, so I won't talk for much more. Purpose of tomorrow is to get the basics of refreshing the action plan. We do many things quite well, and there are some things that we may do better. So 2 questions that you should think about going into tomorrow. What are you and we already doing? And if you could make one change in Sheffield to end poverty, what would it be? Neither I nor anyone else can hold any of the individual actors to account on that one, but your actions collectively and individually do matter. Board are asked 2 things. 1, endorse the recommendations in the report. Secondly, commit their organisation or sector participates in that refreshing of the action plan, which starts tomorrow. That's it, Chair.
Are there any comments? Just for clarification, tomorrow afternoon, for those who don't know, there is a conference, an afternoon conference on poverty and what we're doing in Sheffield. And I think one of the things that is really important is to have that positive outlook as well. You know, going back to what Fatima said at the beginning, is having that optimism bias, because otherwise it becomes really depressing, because we're doing such great things in the city already. Thank you. And I think we're moving on. Are members happy with the recommendations? Brilliant. Thank you, Greg. And we're moving on to the final item, which is the minutes from the last meeting. They are on page 115 of the pack, if you've got it in front of you. Can I accept these as a true record of last meeting? In terms of matter arising, because I have to sign them, I have to go, so I'll go through page 115. 116, 117, I have a matter arising. We will ask Martin. I couldn't see in the report at 26.4, we noticed an understanding that people keeping well budget. I couldn't see like an explanation of that. I don't know whether that has come back. If we could just remind him for next time. I think we're nearly even now. There's a slight overspend now. So it'd be interesting. I think I know the answer, but just because it's in the meeting. Page 118, 119. Page 120, 29.5, I have a matter arising. Did we get the letter response? We might have had it, but I can't remember.
No, we've not had a response.
Okay, thank you. So we've not had a response. Could we chase it? Thank you. 121, 122, and on page 123, which you'll be glad to hear is the last one, in the last bullet point, it says Sheffield Hallam University plan was scheduled to be discussed at the college, health, wellbeing, etc. Fiona, did that happen?
Yes, it did. And I think, Greg, you also came into university as well, didn't you? Met with our VC and yeah. Yes.
I'm being scheduled to go to the exec board at some point in the not too distant future. I don't know the date.
Brilliant. As this is the last meeting of the, so the minutes, no matter to say, so the minutes are accepted. There isn't a date for the next meeting because the meetings will be a timetable after the AGM of the council in May. Greg, did you want to come back?
Minor AOB. As it's the last meeting of the year, the municipal year. Thank you, Angela and Zach, for chairing us through the year. It's been a good year. Thank you.
Thank you very much for sticking with it. See you next time.